Okay. Thanks, everyone. Hi, my name's Leanne Roddy. I'm one of the Grade 4 clinical leads in MUSC in the advanced practice and the acute specialist clinics space. On behalf of Sue Parslow, also Grade 4 in MUSC, and the whole of the MUSC CL Clinical Leadership Committee, we'd like to welcome you to the Pain Forum today. Firstly, I'd like to say a very big thank you to the Working Party, many of whom will be speaking in our presentations and on our panel discussions today. And I'd particularly like to thank Carlos Bello, who's put an enormous amount of work in preparing the forum for us today. So thanks very much. It's been a lot of work and a lot of time and a lot of thought that's gone in. So we hope you really enjoy it today. The presentation is going to be recorded, as you would have known. Again, if you're not comfortable, you can turn your video off, but it will be available up on iLearn for future reference or for those that can't make it along today. We've already alluded to, if you're part of a group that's attending, can you please put the name of who's in your group in the chat function? So we've got a list of the participants that are also attending today. And if you're not already on mute, can you please just make sure that you're on mute? There'll hopefully be an opportunity for Q&A later on where you'll be able to unmute yourself if necessary, but if you can remain on mute throughout the presentations, that would be great. We'd like to commence the forum with an acknowledgement of country. So we begin today by acknowledging the traditional owners of the land on which we are meeting today and pay our respects to the elders past, present and emerging, and I extend that respect to Aboriginal and Torres Strait Islander people that are here today. Next slide, thanks Carlos. So a bit of housekeeping to start with. So we've got a pretty packed agenda, like we said. Again, I've just touched on this for most of the forum. Again, if people can please stay on mute. Use the chat function. If we can't respond to it in real time, we can potentially follow up and we'll have a list of the questions at the end if there's things that we need to follow up afterwards, and we can potentially go back to those in question time. It is going to be recorded, as I mentioned, and hopefully uploaded to iLearn, and we'll let you know where that's going to be in future state. We've got an evaluation form, which we'll ask you all to please complete, and hopefully individually, if possible, for those that are in group situations. We'll put a link in the chat function. And just before the break, and we'll also repeat that at the end. So if you can please complete the evaluation, let us know what your feedback is from today, and also maybe some ideas for future PD opportunities down the track as well. Next, thanks, Carlos. So just to give you a bit of an idea about the outline for today, again, we've got a number of things which we're going to cover off. The first part is really just talking about the why are we doing the Pain Forum today? What's been identified as a need across the organisation, how do we understand that? And then Carlos is going to spend a bit of time talking about chronic pain assessment and principles. We've got two really great case-based presentations with panel discussion, and then we've got a break in the middle of those, two presentations, and then we've got an overview of the ambulatory pain management service at the end. Thanks. Before we launch into the forum today, I just want to introduce you, if you don't already know, to the Musculoskeletal Clinical Leadership Committee. Hopefully you know who your representative is in your clinical stream, so who that person is that you can reach out to if you've got concerns or maybe you've got ideas about what you'd like, particularly in regards to the work plan that we have, which sets our strategic direction for the musculoskeletal service in physiotherapy at Eastern Health. So these are the people that are on the committee. We've got a much broader range of our clinicians who are part of the Musculoskeletal Clinical Leadership Group. And we really invite you all to get engaged with the activities that we're doing aligned to the MUSC CLC, and really welcome your feedback at any time. Next slide, please. Show you some of our smiling faces. Hopefully you'll recognise the people that are working in your clinical teams, but obviously going from top row to bottoms, left to right. So myself, top left, Sue Parslow, Kathy Senseric, Claire Dwyer, top right. And then we've got Linda Wobbling, Hannah Sharma, Janet Tam, Liz Wintle, Steph Walker down the bottom left, Jan Venner, Matula Weeks and Claire Bowman. And again, a number of these people are presenting today. So thank you to everyone. Just to give some context and some background. So chronic pain is a big problem in Australia and globally. Around 1 in 5 Australians live with chronic pain, and the number is projected to rise in future years. Chronic pain is one of the world's major healthcare needs, with serious financial and social implications for individuals, for families, and for communities. Best practice in pain management involves care delivered by inter and multidisciplinary care teams under the biopsychosocial model. Despite the need for skilled health practitioners from multiple disciplines to address the growing burden of pain on our community, there's generally limited pain management content in health practitioner education at all levels worldwide. In Australia, pain management education varies greatly across health practitioner domains and disciplines, and also across geographical locations and education stages. Next slide, thanks. So to address the gap, the Australian Department of Health developed a national pain strategy in 2010 and published the National Strategic Action Plan for Pain Management in 2019. And there's a whole range of strategies, including education strategies to address upskilling of workforce. And this kind of dovetails at a very local level into some of those broader strategies. There is a whole document available, and I've included the hyperlink there if people want to go and have a look at what that looks like. So across Australia, the awareness of pain and pain management is low, as we mentioned, across health practitioners, and it's often discordant with the contemporary evidence around what is effective treatment for patients with persistent pain. Next slide, please. So one of the goals of the National Strategic Action Plan for Pain Management is that all health practitioners are well informed and skilled on best practice evidence-based care and are supported in delivering that care. And that is right down to the education and the knowledge that they hold to systems that deliver care to patients with persistent pain. And there's a number of projects currently underway to develop that pain management education strategy for all of Australian healthcare practitioners, physiotherapists, medical and others. Thanks. So why do we need the Pain Forum at Eastern Health? So recently we've completed the Eastern Health Physiotherapy Scope of Practice, and our data showed us very overwhelmingly that across Eastern Health Physiotherapy in all areas, not just MUSC, but across all clinical streams, there was low confidence in assessing and managing patients with persistent pain complaints. And as I said, the consistent theme across all the clinical streams, that was the most common area identified for development, mapped to scope of practice findings. So the goal of the forum is to commence and support our teams to feel more confident in providing high quality care to patients with pain presentations. And we hope that this forum is used as an introduction to start a more comprehensive strategy about how we can support workforce in upskilling and being confident in managing patients with persistent pain at Eastern Health. So our first speaker today is Carlos Bello. Hopefully most of you may know Carlos. Tends to weave his way into all the areas across the Eastern Health Physiotherapy, which is fantastic. So for those that don't maybe know Carlos, Carlos is currently the team leader for the Ambulatory Pain Management Service at Eastern Health. He has previously been the team leader for the Acute Musculoskeletal Outpatient Service, and he's got a significant amount of clinical experience in the private sector. He has a Bachelor of Physiotherapy and a Master's in Musculoskeletal, and he's completed postgraduate education in pain management. He also runs a not-for-profit non-government organisation in the Philippines to support education for physiotherapists. Please correct me if I'm wrong there, Carlos. He works as a reviewer for Asilvia, and he is also an independent medical examiner for complex case presentations. So thank you, Carlos, and we welcome you to the Pain Forum.
Thank you so much. Now I'm just going to share my slides. Give me 2 seconds as I transition to that. All right, can you guys see that? All good? All right, so what we're going to do is we're going to talk a little bit more in depth about the needs analysis that we did. So part of that was the scope of practice, and then what we did was we did some additional types of needs analysis to support what we saw in the scope of practice, just to also then determine what is the requirement for Eastern Health physios in chronic pain. Then what we're going to do is we're going to introduce 8 different pain concepts, And because I have limited time and, you know, the whole sort of the icing on the top for the Pain Forum is the case presentations. So we're going to go through and blitz 8 different pain concepts. Then we're going to move over to the pain presentations. There's 2 pain presentations with Vince and Andrew doing the case presentations, and then we've got some panels, and then obviously I'm going to be talking about the ambulatory pain management service. So let's get into it. Needs analysis. So this is on the right is a picture of the scope of practice sort of readout. And I've got a better I've turned that into pie graphs in a second. But obviously we did the scope of practice. It was, we were asked to use the Bondi scale, which is level of confidence and also the frequency of use of those skills. All in all, with regards to the questions with the relating to pain, they were relatively vague and very difficult to kind of decant into, you know, what does that actually truly mean? And therefore, we needed to do some further education from the MUST CLC point of view. Within the scope of practice, there were 3 very, very specific chronic pain questions. But as you can see from the readout on the right-hand side, that there's a lot of other questions that were related to pain. So with the 3 questions, I'm going to be presenting those 3 main questions. So with the 3 main questions, the first question was conduct a pain assessment using the core principles of basic pain neurosciences, considering the biopsychosocial model and the scientific basis for pain assessment, diagnosis and treatment to identify risks and flags as appropriate across the continuum of care of an individual. That's a long sentence. And I guess the combined, so all of physio within Eastern Health who completed the scope of practice, the green is good. A lot of people say that they feel that they're independent, 62%, 29% said that, that they were supervised, and 9% said that they were assisted. If we split those into the grades, what you can see is that all the grade 3s are independent, and that's probably what we expect, right? Grade 2s, 2/3 say that they're independent, 28% say that they're supervised, and the grade 1s, 38% independent, almost 50% supervised. So I think that's pretty stock standard and the expectation. For the second question, indicate your level of confidence in your clinical practice relevant to managing persistent pain syndromes. This has a bit of there's a bit of a change to the result here. So the number of percentage of independent is drops down to 18%, supervised 53%, and 29% feel like that they need to be assisted. If we again decant it into the different like what we expected. I guess what's interesting is that the grade 3s feel like that they're a little bit more, that they require a little bit more assistance compared to the grade 2s. The grade 1s, 50% feel that they're assisted. So the third question incorporates knowledge and application of appropriate assessment and management techniques for persistent pain. It's the same sort of thing again. So we've got almost 50% feel like they're supervised, 25% feel that they're assisted, 30% feel that they're independent. With regards to splitting it up again, grade 3s said that they're 50% feel that they're supervised. The grade 2s, 43%, and then with regard to the grade 1s, 47% assisted, 47% supervised, and only 6% independent. I think this is kind of normal, but I think that there's some inferences that we can make from that. But what we did was we did some other needs analysis to completely understand, or at least get a better understanding of what we're sort of dealing with. So this is actually the first pain principle as well. So this is the neurophysiology of pain questionnaire. So the neurophysiology of pain questionnaire, the origins of it is that it used to be a master's exam for masters in pain management. It was then converted into its clinical applications. So it's been validated for pain populations, and it was devised as a method of assessing how an individual or a patient conceptualizes pain. And what you can do from a clinical application point of view is that you can ask your patient to do the questionnaire. The things that they get wrong are sort of areas that you can look at with regards to the neurophysiology of pain that you can correct. And that should assist with their recovery. There is some research to suggest that using this in a clinical setting has a positive effect. The neurophysiology of pain plus physiotherapy has a massive effect. So it can also be used for workforce development, like what we did with physios. So we actually conducted the neurophysiology of pain questionnaire on a variety of physios from Eastern Health. Just to let you know that the average health professional without pain training gets 7 out of 13 correct. A patient in the wrong direction. So here's some results. So
hey, Carlos,
we did what's that?
You just cut out for quite a bit.
Oh no!
But
okay.
It has a massive effect for physio and with physio and using the questionnaire with clients.
Correct. Okay, gotcha. Sorry about my my internet connection. So with regards to workforce development, what we know is that the average for health professionals is 7 out of 13, which is not bad. So health professionals that have no postgraduate training in pain. And, you know, it's what it means, though, is almost 50% of the time, health practitioners are not providing correct neurophysiology of pain education to their patients, which may be directing their patients in the wrong direction. So we conducted the neurophysiology of pain questionnaire on a few physios within Eastern Health. So grade 1 physios, we had 11 conduct this for us. We had 11 grade 2s and we had 6 grade 3s. And if you have a look, this is their results. So each one of those, so the series, it says 8 out of 13, 11 out of 13, etc. What you can see is the mean. The mean for grade 1s is 10.82. So congratulations to the grade 1s. That is a very, very high level of neurophysiology of pain education that you have got in your pocket there. Grade 2s actually have less. So your the mean is 1.2 points down. And the range is actually larger in grade 2s. So have a think about that. Grade 3s, as you would probably expect, their mean is 11.5. So another step up. So in comparison, the grade 1s are saying, you know, we require a lot of support and assistance with regards to, you know, managing pain syndromes, but their neurophysiology of pain questionnaire is quite high. For grade 2s, they are saying that they, you know, that they require supervision with regards to managing pain syndromes, and the neurophysiology of pain is a little notch down from the grade 1s. Above average, so above the 7 out of 13 average, but still lower than the grade 1s. And as you would expect from the grade 3s, they should be going okay. So we did a set of structured interviews, and thank you very much to the people that participated. It was kind of long and drawn out for them, I guess, and I was asking a lot of open-ended questions. The open-ended questions were exploring their knowledge, their attitudes, practices of persistent pain. I asked them about their day-to-day experience, the resources that they go to, and some stories and how they troubleshoot things. So we asked a lot of grade 1s and a few grade 2s to participate in this. And the new grads, what we did is we got a big spread from the new grads to, oh, sorry, the grade ones. We got a big spread from the new grads to the 6 or 7 years out. So I've got some thematic analysis slides. So, and I've got some quotes. So I'll just go through them. So general comments is, I was speaking to my supervisor last week, getting a lot of low back pain through the ED and general med. My grade ones have it in their learning goals: back pain, pain management, complex pain. In ED, it's hard to know a lot about triaging. What I would like to improve on is beneficial advice and exercises for the patient. Would like to be able to do a very good assessment in the acute setting. Another quote, I think the other areas is when to advocate for imaging, particularly in patients with no history of trauma, patients that are presenting with mild sensory changes and shooting pain. When is imaging or a trial of therapy indicated? Other general comments is differential diagnosis and working out which exercises are going to be right for them: neurological exam, palpation, body tenderness versus muscular. I don't tend to do lumbar range of motion assessment. Assessment is more functional instead of trying to find out what's going on. Screening for red flags is important, teaching them management strategies to get through and referring them on. I think it would be good to have an idea of the potential differential diagnosis to be able to provide education to patients. Another person said, I'm rubbish at MUSC differential diagnosis. I have a lot of interest in chronic pain. I sat in on the APMS Zoom. Good for you. I was going to do the pain course tomorrow. APMS patients had an inpatient rehab stay, large psych history, I'll just summarize this, very confused about the whole thing. It's hard to focus on what specifically to do on each session. With regards to pain assessment, they said that they don't do very much at all. Do you have pain at the moment, and score it out of 10. Other people have said how it changes over the 24-hour period. Describe the pain. What are the AGs? What are the eases? Make a big emphasis on the function and capacity that they still have. And I think that that's probably like rooted on, and that's really good with CRP. CRP have like a patient-specific functional scale, and out of 10 pain for a 20-minute walk. Haven't had too much exposure. When had someone, it's usually secondary. In settings I've been in, we don't usually have a look at it. The way the patients describe the pain, down demeanor about it, having all the pain, don't know what to do about it. I used a questionnaire once, Oswestry, can't remember what it was, body chart, a lot of subjective, try to pick up on the flags. So with regards to undergraduate training, as a summary, only three lectures and 1 tutorial, or 2 to 3 hours in total. Never went through the treatment or the management. So EH, day-to-day experience, where it gets tricky, if more than 3 months, still painful total knee replacement, can't contribute it to the surgery or attribute it to the surgery, what is the source? What do I do with it? Someone said in acute ortho ward, pain in that setting is a lot more acute and black and white. Someone has pain, you go to the nurses, you get the meds. In community, you're looking at long-standing pain. In general med wards, where there's an exacerbation of chronic lower back pain presentation, in this case, it's a bit tricky. Doctors are biomedically focused and an intervention, and it would be good to actually be able to provide something for these patients. In outpatients, getting back to recreational activities, find it quite challenging because you have to unpack everything within the 30-minute timeline. Another day-to-day experience, you're seeing them for something else. I don't ask about the pain because it can open up a can of worms, and I can't spend that much time talking. Patients had an acute on chronic presentation, refusing to leave hospital. A lot of that got put on the physios. Didn't know how much to do with her. She was already being reviewed by medical team about analgesia. I was very lost in that situation. With regards to PD requests, so people asked for criteria for the pain management clinic. So we will be putting that in at the end. Different types of assessment of chronic pain patients, we'll be definitely putting that in. If you pick up someone is not progressing as expected, how do you deal with it? What sort of language do you use? What sort of language do you use to not induce chronic pain? Maybe a flow chart would be really good if we're stuck. Other continued professional development requests, a place where resources are. And I believe that everybody knows about iLearn, and that there's structures in iLearn that are growing day to day to support our clinical needs. More about that later. For more complex presentations, you ask all the ags and eases, and then what do I do with that information? The big gap is knowing what to do. I'm a bit lost. Developing a treatment plan. What is the clinical reasoning behind it? Other people have asked, how quickly do these treatments change and what to expect from the treatments? And others have said, would like to be a little bit more confident about figuring out the pain source. So private practice physios work it out in 2 sessions, whereas I work it out in 7 sessions. And skills around narrowing up the subjective or getting that better. So as a summary with regards to the interviews, it looks like, physios are interested. I think that they are sort of also saying that they are frustrated with their lack of ability to help those that are truly in need and to get down to the source of it. And they're wanting resources and practical applications, in particular with regards to like the clinical reasoning and differential diagnosis. As a summary of this sort of needs analysis, we saw that the gap is not in the biopsychosocial. And if we did this kind of needs analysis in a private practice, you would see that the biopsychosocial would probably be lower. Whereas here within our network, Eastern Health, it looks like the biopsychosocial stuff is really well done. And we have that really, we have good foundations in the biopsychosocial. I think the biggest gap for us here is more the mastery of the basics. Hypothesis testing, differential diagnosis, clinical reasoning, and actually the role of manual therapy. So I've already talked about neurophysiology of pain questionnaire. So I only have 7 pain concepts to discuss. So let's get at it. So I want people in chat to actually just say, why are we talking about pain concepts? Like, why would we do this? So if you can do this really, really quickly, why would we do this? Why is it important to discuss pain concepts? Pain is complex. Thanks, Eddie. So we're all on the same page. Pain is different for everyone. I like that. So you said they're all on the same page. I like that, Nancy. Janet and I talk a lot about developing a language that we can all sort of have. A lot of people just go, oh, this person's got chronic pain. What does that actually even mean? And so like developing a language is definitely one of the big things. Pain is different for everyone. Help provide structure. Yes, Amy, awesome. Structure in thinking and reasoning, because it directs the rest of our education. It directs all of our treatment. Janet Tam, pain is multifactorial. Andrew says, gives structure to someone that can be abstract. Yes. Gives a construct. Thanks, Leanne. People in pain are complex with multiple comorbidities. Perfect. All right. So yes to all of them. And I'll try to connect that back, because I think one of the key things that we want you to do is to be able to sort of have this as a practical thing, and that you can actually bring it to your clinical practice straight away. So I wanted to just share about the scope of practice for persistent pain that the Alfred created on behalf of the Department of Health of Victoria in 2014 for physios in the pain clinic. And if anyone is interested in chronic pain and wants to be a chronic pain physio, this is something to look at and kind of go, okay, tick, I'm good with that. No, I'm not good with that. I'm going to go and do some further study on that. So the scope of practice for advanced physio, MUSC physios in the pain clinic includes triage, multi and single discipline management of patients presenting with pain conditions, include acute, subacute, recurrent, persistent, nociceptive, neuropathic, and mixed pain. The physiotherapist is responsible for assessing, diagnosing, formulating, and undertaking a comprehensive management plan alone and in conjunction with expert colleagues. I'll leave it at that. So with regards to, they do a breakdown of the domains, the broad domains, and then these parts are the elements. So for example, the domain of professional behaviors, obviously you want a pain physio to operate within the scope of practice, display accountability. In the domain of communication, you want them to be communicating with their colleagues. With regard to the provision of and coordination of care, you've got all of these different things. What I'm going to do is I'm just going to highlight this, perform assessment and examination. So with it, within this document, there's criteria, performance criteria and performance cues. So this is the performance criteria, performance cues. If you want to look that up later, it actually gives you a sort of what is expected of you to know. And it's a really good sort of scope of practice for myself and Eddie working in the pain clinic. So 6.1, design and perform an individualized, culturally appropriate and effective patient interview for common and complex pain conditions. Formulate a preliminary hypothesis and differential diagnosis. Perform modifications to routine musculoskeletal assessment in recognition of factors that may impact the process, such as patient profile, needs, and practice context. Design and conduct an individualized, culturally appropriate and effective clinical assessment that is systems-based, includes relevant clinical tests, selects and measures relevant health indicators, substantiates the provisional diagnosis. That's one of the things that, that I really want to highlight, substantiating your provisional diagnosis. Identify when input is required by expert colleagues. Act to ensure red flags are identified. Act to ensure yellow flags are identified. So my third pain concept is the APA position statement. And this was done in 2012 and was supposed to be revised in 2016. I can't see what I can't find the 2016, but I love it. I love the position statement. So with the position statement, what they say about pain is that current understanding demonstrate that complex neural processes produce pain and that modulation of the pain experience occurs at multiple sites in the periphery and throughout the nervous system. Many factors can affect the intensity and the quality of pain. So internal factors and external factors. Biopsychosocial approach is important, more important than the biomedical approach. So as part of that document, their recommendations for acute pain is pain education. So like neurophysiology of pain questionnaire, pain education, assurance, advice on resuming normal activity, and discussion of options for pain management as needed. I think we do that really well within Eastern Health. I think the next point we don't do great. Techniques such as manual therapy should follow international best practice guidelines, and their efficacy should be measured by objective measures at regular intervals. Prevention of transition transition to subacute and chronic pain. So in the acute pain state, you want to be looking at preventing a person to progress to the subacute and chronic pain. So psychosocial factors, screening for those. Clinical guidelines are consistently recommending early detection and early intervention for best results. Refer to psychology. Recommendations for chronic pain. Again, this is why I really love this document, because acute pain strategies are also useful in chronic pain. Later in our in the information about the pain management service, it's got, has this person had appropriate trial of acute therapy? So acute pain strategies can be useful in chronic pain. Okay, it's not like a no, it's more let's reason it out, let's justify it. But inside of the chronic pain, intensive multidisciplinary biopsychosocial rehabilitation is the best way. So it's considered the most cost-effective, and it involves, you know, the full everything. So graded exercises, optimizing functional independence, education about pain, pain sciences, lifestyle modification, looking at different psychosocial factors, working with families, employers, and other parties involved in the person. So this is my fourth one. How am I going, everyone? Okay. So this one is a differential diagnosis algorithm, and it's by Nijs in 2015. So he says that lower back pain is heterogeneous. It's a heterogeneous disorder, and it includes patients who have nociceptive pain, neuropathic pain, and central sensitization pain. And it's important to be able to distill and to actually decide on what is the predominant kind of pain style in order to select effectively and to be able to treat that person effectively. So the next few slides is a little bit about a discussion about nociceptive, neuropathic, and central sensitization pain. In a second, well, actually, what I want to do is, so I want people to chat, go in the chat. And so what Nijs says is that neuropathic pain is considered the easiest to diagnose. So can I get some responses in chat to let me know what makes you think that something is going to be a neuropathic pain? When do you sniff out that something is that is neuropathic pain? Box Hill, shooting, burning pain, referred pain. Okay, good. Okay, myotomal, dermatomal reflex impairment. Very good. Okay, Vincent says the nature of it is distinct: burning, electric type. Yeah, pattern and nature of the pain. Perfect. Okay, cool. Any other responses? What about so that's like the subjective. So like how a person describes the pain. What about things like objective? What about things like past medical history? Those sorts of things. What would make you think that someone has neuropathic pain from their past medical history? Okay, no answers. Hypersensitivity, yes-ish. Okay, I'm going to move on. Replication of symptoms with neuroprovocation test. Okay, diabetes, yes, well done, Eddie. Diabetes, comorbidities. Hannah, what kind of comorbidities? Leanne also said diabetes. Neurological diagnosis, beautiful. Thanks, Renita. Perfect. Spinal injury, good. All right, so here's the slide that will tell us all the answers. So yeah, herpes, zoster, shingles, very much so, Eddie. So neuropathic pain, is there a history of a lesion or disease of the nervous system, central or peripheral? Are there comorbidities present? Things like cancer, stroke, diabetes, shingles, neurodegenerative diseases. Pain distribution in neuroanatomical location. Burning, shooting, prickling, like Vince said, and then location of the sensory dysfunction, neuroanatomically logical. Okay, so that's good. So neuropathic pain, a lot of people are pretty good at that. So we'll just put that aside. So the next thing is, this is, I'm going to be summarizing this, but if you want to go back to the article, this tells you about how to separate somatic versus central sensitization. Okay, so 3 criteria. Central sensitization pain, subjectively, in your subjective examination, is disproportionate, non-mechanical, unpredictable, and it's unpredictable provocation. So AGS and EASES, unpredictable. Okay, so that might be someone that says, oh, you know, I could just be going and doing this, or I could be just going and doing this, and they seem quite like non-mechanical, like you're thinking like, oh, it's a facet joint, and then it actually like does not act like a facet joint completely. And then the second point is disproportionate, inconsistent, non-mechanical, non-anatomical patterns that we know as physios. So with regards to our movement and mechanical testing. So in our objective examination, when we go to do an examination, like a functional examination, as well as active range of motion tests, etc., and special tests, that it won't respond as we expect it to. And non-central sensitization, it's very clear, it's proportionate, it's mechanical. You know, our hypothesis is this, and it mostly fits it, right? that in our subjective and that in our mechanical and movement testing. Okay, so it might be something like, for example, someone has some neck pain, and when you turn to the right, it causes pain. And then what you do is you go, okay, I think it's a compression thing. So what I'm going to do is I'm going to apply a mini treatment of a little bit of traction, and then do that for 2 rounds of 30 seconds, and then reassess it. It's better. So your mechanical testing actually supports a clear and consistent proportional mechanical hypothesis. Other things is the second criteria is the neuroanatomically illogical pain pattern. So something that is not plausible from our pain or our sort of normal concepts of like normal mechanical pain. So examples of this are bilateral pain, or pain going from one side to the other, pain varying in anatomical sites, pain and neurological deficits that are beyond one segment. So for example, that spans over like 3 segments, but also don't forget those red flags where, you know, that might actually be like a cancer or something that is affecting 3 segments. So widespread pain, allodynia, hyperalgesia, referral patterns that are not logical. So the logical referral patterns that we have are Cloward signs, for example, and musculoskeletal or myofascial pain, right? So we know that, for example, like a C1-2 palpation will cause a Cloward sort of referral pattern to the sort of shoulder. So if it doesn't meet our normal expectations, then it may be more of a central sensitization situation. The other thing is hypersensitivity. So prolonged hypersensitivity is one thing. So heat, cold, mechanical, all those types of sensitivities can actually suggest to you that someone has central sensitization. There's also the central sensitization inventory. If you want to look that up, you can actually use that to sort of improve your definition of central sensitization, but also you can ask your patient to do it, and that might give you a better sense of whether they're actually centrally sensitized. Just also on hypersensitivity, hyperalgesia and allodynia, you know, if you twist your ankle, immediately what you'll get hypersensitivity and hyperalgesia in the surrounding area of your ankle. So it's not distinctly for chronic pain unless it's for a long period of time. Like you will get sort of hyperalgesia, allodynia in normal states as well. But is it as expected? That's up to you to judge to determine whether someone has central sensitization. Okay, so my 5th one. I'm going to stop sharing for a second. So my 5th pain concept, can I please get Ping up? Ping, can I get you to take your video, put your video on as well? Tessa and Nathan. Where's Nathan? And if Nathan doesn't jump on, who can be like my emergency person? Is that Nathan? Box Hill? No. So Ping's there, and we've got Tessa there. Thank you. Who wants to be the 3rd person? If we don't have a 3rd person, that's okay. All right, so we're going to play Jeopardy. So I'm just going to share a screen again. So Jeopardy. So Jeopardy is an American TV show where we provide the answer and you have to chime in before your competitor, right? Ping's really good actually, Tessa. So just watch out for her. You need to answer real quick, all right? But how you have to answer is, for example, like I will provide you with the answer and then you have to answer with what is, and then something. For example, what is allodynia? Okay. So Tessa and Ping, can you guys get yourself off mute? And can you please test your buzzer, which is your name?
Tessa.
And then Ping?
Ping.
Okay, cool. All right. Ping, got to be loud, all right? I feel like you're going to win this. Okay. All right. So the first one is for $200. For $200, the common symptoms of this is avoidance of places and situations, feeling nervous, restless, or tense, a sense of impending danger, panic or doom, increased heart rate, hyperventilation, sweating.
Anxiety, Tessa, anxiety?
Correct. This is your first warning. You have to answer as what is anxiety.
Oh,
Okay.
okay, sorry.
All right, $200 to Tessa. Okay. For $400. This is a mood disorder that causes a persistent feeling of sadness and loss of interest.
Depression. Ping, depression.
Okay, Ping, well done. Again, what is depression is the correct answer. I will pay that. Come on, guys. Come on. All right. Okay, for $600, a mental health condition. Actually, I won't do that. Okay. For $600, symptoms are generally grouped into 4 types: intrusive memories, avoidance, negative changes in thinking and mood, changes in emotional reactions. Symptoms may include poor sleep, increased psychological arousal or physiological arousal, sorry, widespread body pain, a mental health condition that is triggered by a terrifying event, either experience or witness.
What is post-traumatic stress disorder?
Correct. So Ping, you are on $1,000, and Tessa, you are on $200. Okay.
I like there was a bit of throwing there. That's okay.
We might get a draw actually. So for $800. All right. You ready, Tessa? You ready?
Let's do it.
Okay. So characterized by 3 tendencies: rumination, magnification, helplessness. An exaggerated negative mental state brought to bear during actual or anticipated painful experience.
Ping, what is catastrophization?
Correct.
Well done.
Well done, Ping. Congratulations. You absolutely just smashed Tessa.
True, very true.
Hey, you did well. Thank you, guys. Thank you for being such good sports on that one. Okay, so you know, one of the really interesting things about this is that that almost all of them will have widespread body pain. All of those have widespread body pain. So I'm obviously talking about biopsychosocial, the psychosocial. So they did some research about physios and their attitudes with regards to the biopsychosocial. So whilst physios theoretically support a biopsychosocial approach to lower back pain, in practice, very few are doing so adequately, despite training in cognitive behavioral principles. Even recently graduated physios demonstrate some attitudes and beliefs about pain that are not fully in line with lower back pain guidelines, okay? So 3 things. Physios only partially recognize cognitive, psychological and social factors in lower back pain, with most discussion around factors that are such as family, work, and unhelpful patient expectations. So pretty much what we do is that we veer towards what we're most comfortable with regards to the screening of the psychosocial. The other thing is that physios tend to stigmatize patients with lower back pain. And we actually label them as demanding, attention-seeking, poorly motivated, lazy, when they present with biopsychosocial type of behaviors. Patients question the relevance of screening because they were perceived as extending beyond the scope of practice. I think, you know, what I was saying with the needs analysis, I think we're pretty good at this. So I'm just doing this to cover ground to make sure that I'm complete with how I'm talking about things. Now, can I get a volunteer to talk about the flag system? I'm outsourcing these slides. Can I get a volunteer to talk about the flags? No volunteers. Okay, cool. All right. So we all know about the flags, right? So these are associated with, these are recognized as factors associated with people with back pain and actually will lead to poor outcomes. And in a further slide, it is a direct correlate. Okay. So we need to have a look at these flags. So we have all these different flags. So we're all aware of the red flags and the yellow flags. The relatively new flags are orange flags, blue flags, and black flags. So red flags, as we know, serious pathology, things like chorda equina, fracture, tumor, those sorts of things. And we have our sort of, red flag questions that we do routinely. With regards to orange flags, it used to be part of yellow, but it's been sort of separated. Orange is diagnosable psychiatric conditions. So things like diagnosable depression, post-traumatic stress disorder, etc. And obviously we have these flag systems to actually guide us to what we're actually doing with this person. So if we know that someone's got PTSD and it has not been managed, then we need to refer to get that support from the appropriate health practitioner. I'll talk about yellow flags in a second. Blue flags is perceptions about relationships, about work and health. So it's perceptions. So blue flags is, a worker's perception of their boss, of their work, of their workmates. And it could be someone saying something like, oh, I was there for 15 years and they're not talking to me now. They're not helping me out. I used to have the keys to work and now they've taken that away. I haven't been back. They don't even talk to me. Or I've been bullied at work. Or my colleagues don't actually help me with my return to work. So these are blue flags, and it's important to sort of like look at this and to screen for these blue flags. And it may be one thing that you could potentially be doing is working with the other health practitioners to start to have conversations about the workplace, to have conversations with the GP and the boss or the manager to support these kinds of issues. With regards to black flags are systemic or contextual obstacles. So things like litigation. So I don't know if you've had sort of workers that have said, oh, my lawyer told me that I need to attend this. And they're going to independently medically examine me tomorrow. So, what's the luck that you'll have any effect on that process? Sometimes in my clinical practice, I've said, actually, let's just not, like there's legislation in the near future, let's not sort of interact just yet. Let's wait until this is done, and then let's do active therapy. Other things that's more appropriate to the public system are things like NDIS, or other things would be TPD, total permanent disability. Other things are things like work. So work, but the systemic aspect of work. Like, for example, the person has heavy work, or their work duties are non-changeable. And in that sense, what you might need to do is, well, firstly, ask the questions. So then you're aware of it, like the black flags, and then start to kind of go, okay, well, if it's heavy work and that's sort of like an issue there, maybe, the conversation will be about, have you considered using the skills that you've already acquired and re-educating so it allows you to be involved in a less physically active job. So that's why we sort of like look at the flag systems, or how the flag systems can be used. With regards to yellow flags, again, it's beliefs, emotions, pain behaviors. And what I can say about yellow flags, so things like unhelpful beliefs, things like, my doctor said that my back is the worst. Have you seen my MRI? My disc is out. It's crazy big. Other things are, my friend is wheelchair bound. Other things are, so pain behaviors, fear avoidance behaviors, or people that overdo things, people that are reliant on passive treatments. So just a comment about this. So as you ask about these things, what you might need to do is you might need to be educating people about it. But the other thing to note about yellow flags in particular is sometimes these things, like catastrophization is a yellow flag, right? These things arise from poor education about what's going on. Nobody's explained this to me. Nobody's explained the X-rays and what they mean, what they truly mean, not what the threat of it, but what they truly mean. And we'll talk about that in a second. But also actually getting the right treatment. If someone came to the pain clinic with a twisted ankle and I tell them, you know, we're going to go and do this pain education and we're going to do all this sort of stuff where you actually just need to do acute therapy on them, then of course you're going to develop these yellow flags. So just to sort of like give relevance to, you know, that yellow flags can arise from something not being done in a timely manner from a physiotherapy point of view. Screening questions that you might want to ask, have a read of this yourselves. One of the questions that I love to ask is, you know, what do you understand or what have you been told about your pain? What's your GP told you about your pain right now? What have you been told about your MRIs? So have a look at this slide when we distribute the slides. But there's some good sort of questions that you can add to your armory of questions that you might want to ask, but I know you guys are time poor, you know, in the CUTE especially. So this slide is about the correlation. So this top one is there is a strong relationship between psychosocial yellow flags and orange flags and clinical and occupational outcomes. So for example, this linear thing, so the worse something gets, the worse that your pain and disability gets. So this positive strong correlation is for people with like yellow flags, orange flags, blue flags, black flags. So with regards to depression, depression is one of the strongest ones. If someone has depression, you are a fool to not think about what that implication has, because there is pain and disability that will come from that if you do not look at that as part of your treatment, holistic treatment plan. Okay. What is a poor relationship? As we know in recent research, investigations. So recent 10 years of research about asymptomatic patients doing MRIs on asymptomatic patients, they got issues in their back too, right? It's comparable to the issues that you have with your patients that have pain. So, you know, same MRIs with asymptomatic and symptomatic, there's got to be, well, it's a poor relationship. So the investigations is the poor relationship to the expected pain and disability. Lastly, there is a strong relationship between assessing someone from a mechanical pain and clinical improvement. So if you subjectively and objectively assess someone and you think that they have mechanical pain, you do a mini treatment on them, they improve, there is a positive relationship between you making them better if you can justify that or, you know, clinically reason that that is a mechanical pain. Other thing to mention is that Jull and Zito in their research in 1999, they had people with chronic neck pain. And what they did was people with chronic neck pain, half of them did psychosocial therapy and half of them did manual therapy. All of them had both objective physical examination issues, psychosocial issues. If they worked on the psychosocial issues, everything improved. If they worked only on the manual therapy, everything improved. So I'm going to skip this because I feel like I'm going over time. But this is the effect of psychosocial plus physio. There's a really, really good sort of research base on that. My seventh, almost finished, and then case presentation 1 will be going ahead. So concept number 7 is Lester Jones and O'Shaughnessy 2014. This is the pain and movement reasoning model. So what it does is it attempts to capture the complexity of the human pain experience and tries to tease out in a usable framework for physiotherapists how to sort of start to figure out where we, put our energies in therapy for. Okay, so hopes to lead therapists to select the most appropriate techniques. So this is the triangle, Lester Jones's triangle. He's a psychologist initially, and then he trained to do physiotherapy. I've seen him on Facebook. He's in Singapore at the moment. Anyway, so this top part here is CNS modulation, and these two bottom parts are very physio-specific type things. Really, only a physiotherapist can actually fully understand it. Joking, but these are very physiotherapy centric type of corners of the triangle. So I'm going to talk about them now. So CNS modulation. CNS modulation can be split into three things. So cognitive, emotional, and social. So on the right-hand side, that corresponds to your yellow flags and orange flags and blue and black flags. Okay. Thoughts, beliefs, emotions, current social context. If we go to the left, predisposing factors. So we know that there's a genetic predisposition to chronic pain. So people who have kids who have chronic pain, looking at the genetic predisposition of it. Also, past experiences. So people with PTSD, also people who have torture victims, their central nervous system can be completely spun up and actually cause them to have chronic pain. So predisposing factors, other things would be things like celiac, mental health disease, those sorts of things. Now, prolonged afferent input is, I really love this bit because there's research to support that someone with neuropathic pain can start to have changes in their central nervous system of chronic pain. So it's not actually, research studies say 3 months or 6 months, but it's actually not true. So people who have strong, prolonged afferent input into their nervous system can actually have a switch over into chronicity within hours. So it's sort of like a judgment call for you. So as you're sort of like looking at someone and getting their history, have they had a prolonged afferent input, whether it's like multiple pain conditions or whether they had this, really painful back pain plus neuropathic pain, and it just was unremitting for a few weeks. They could start to have that sort of central modulation sort of effect. These slides, have a read of them in your own time. The regional influences, there's 3 parts to that. So regional influences are things like convergence, and what convergence is actually referred pain. So it could be visceral referred pain. It could be somatic referred pain. It could be your Cloward sign, or it could be your myofascial referred pain. So for example, you could have someone with shoulder pain, but their neck is really, really the source of the problem. So that's a regional influence. The other thing is kinetic change. So, has the person got hypermobility, issues with their proprioception? And, physiotherapists are fantastic at assessing that and starting to treat that. Neurodynamics. So is there weakness? So is there paresthesia? Is there reflexes? That's where your neurological examination goes in. And then also the neurodynamics assessment comes in. Okay, do they have a tight neurodynamic system that is contributing to their pain condition? Again, some more slides that I'll get you to read in your own time. Local stimulation. So is there a mechanical deformity that is contributing to their pain? Like, for example, if you assess them and you compress the joint that you think is involved, or if you stretch the joint that you think is involved, is that an issue in the local system? Other things is chemical stimulation, like, for example, inflammation, effusion, other things maybe like gout. You know, is there a chemical issue in the spot? Okay. So that's a really good one. I really love it. The way that Lester Jones actually teaches it is, if you guys can see this X here, he says, you know, get a pen and just, you know, point it at this part of the triangle. I don't particularly agree with that, because what this means is that you're, you know, saying that it's more CNS modulation and it's less regional influences, and I don't like that. The way that that, you know, the guys, the panelists, and I have talked about it is that we have talked about it like this, where it has to be a matrix. So out of 10, you know, this is maybe 8 out of 10, and this is 10 out of 10, and this is 2 out of 10. Once you've done your assessment, okay, once you've done your assessment, your subjective and objective assessment, then you can start to make a judgment call about how much the local aspect is contributing to it, or how much regional influences. Like, let's say, you know, someone with back pain with hip replacement and knee replacement that didn't go well and it's been stiff. So that would be like someone with regional, like high regional influences. My last one is called EPOC. So EPOC is the Electronic Persistent Pain Outcome Collaboration. In short, what it is that the chronic pain services have come together with EPOC, the Australian Pain Society, University of Wollongong, and actually created a set of routine chronic pain type of outcome measures. And this is the way that we assess our patients to see, you know, to see what we think is their big problems and what directions we go, but also they use it to determine how good we are as a clinic. So at the bottom, it's, well, actually, I'll go through it all. So we take patient and demographic information. We take the information about their work, onset and chronicity of their pain, their usage of healthcare, medication use. We ask them to do a body chart and talk about the pain intensity, their pain interference, and we ask them to complete the DASS, Depression, Anxiety, Stress Scale, PSEQ, Patient Self-Efficacy Questionnaire, and Patient Catastrophizing Scale, PCS. These are the 3 most used outcome measures in chronic pain, because we see that it's a correlate for recovery. Okie dokes, I think that is me. So I'm just going to stop share for a sec. I just want to double check whether everybody that is in the first panel are here. So have we got everyone? So we've got Vince. Can we spotlight Vince? And can we spotlight Tim? And congratulations, Tim. We've got Christine. And we've got Janet. Okay, let me introduce these peeps. I've got some notes. So let me introduce Vince Lenkong. So doesn't need too much introduction. I feel like everyone doesn't need too much introduction, but I will introduce them. So Vince is currently a grade 2 physiotherapist in community rehab in Wantirna and PJC. He's also an academic tutor and research officer in the physio department of La Trobe Uni. Congratulations on starting that. Bachelor of Health Sciences, Masters of Physio Practice, undergraduate at La Trobe Uni. Special interest is rotator cuff repairs and rotator cuff rehab. Our panelists, first panelist for our acute case presentation is Tim Alberston. So Tim is grade 3 physio support and allocations coordinator at Maroondah Hospital, which is that new position. Congratulations on that. Previously grade 2 physio at Box Hill Hospital, Gen Med and ED. Bachelor of Health Sciences and Masters of Physio Practice at La Trobe. Very recently just finished his grad cert in public health in Flinders University. Congratulations, that's 3 congratulations. All's looking up for you, sir. Special interests in assessment, management of acute dizziness, acute pain and discharge planning. And then we've got Christine Bowman. So Christine Bowman is a grade 3 physio and CRP in community health. Previously worked in a pain management service in Epworth. She and I finished physio together about 1 billion years ago. And she has a grad dip in health services management and CSU. Special interests is prevention of acute pain, chronic pain, women's health and exercise, and orthopedics. And then last but not least, Janet Tam, who I'm the massive fanboy of. She was my grade 3 when I was a grade 1, when I freshly graduated, and I still have notes of the time that we've done doubles together. So she is a grade 3 ED, advanced MUSC physio, and is the team leader of outpatients grade 3 there. Previously AMP role in back pain management services. She has a postgraduate master's, which we call MANIPS. So we're manipulative physios. Her special interest is advanced practice ED, back pain management services, differential diagnosis, and clinical reasoning. So I will hand over to Vince. I will continue sharing slides, and I'll hand over to you to do your case presentation. Thank you, everyone, for coming.
Awesome, Carlos. Thanks for that. So we'll go to the next slide, Carlos, if you can. So yeah, my name is Vince. Most of you might know that I'm in CRP, but why am I presenting on the acute management of pain? So I do some weekend works at another private hospital. I won't name which hospital, but if we go to the next one. So the case that I present today, I know Healthscope's on the picture there, but it's not Healthscope. So the case that I've been presenting today is from the time that I was covering an acute ward, and then they were down a physio, and then they said, "Hey Vince, can you cover ED?" I said, "Sure." Not my area of specialty, but okay. So the gentleman that we have is an 84-year-old man. He's home with his retired wife. So he came into ED after 10 days of right hip pain and thigh pain radiating all the way down to the lateral quarter of his foot. So 10 days ago, he went to the doctor, said, "I've got some pain." The GP gave him some endone. 10 days later, it hasn't improved. So then actually within that 10 days, on the third day, he was unable to get off the bed or take a step with his right foot without a lot of pain. He started sleeping on the recliner because he didn't want to go to hospital. But on the 10th day, it became unbearable. So he was brought in to ED by ambulance. And I asked him, "How did you do this?" He said, "I picked up a wheelbarrow full of dirt while I was gardening." Next slide, Carlos. So I thought, all right, let's have a look at the past medical history first. Overall, he sounds like he's quite a healthy man. Had a right total knee replacement in last year, went to Vic Rehab, no complications from, he said there's no residual weakness, there's no there's no inequalities between his sides. So that's all good. Right total hip replacement as well. In 2018, he's a fan of Vic Rehab, as you can see. He went there as well, nil complications, and he had a left total shoulder replacement in 2019. He went to a private physio for that, but when I checked his range for his shoulder, it's all good. So, besides the presenting condition that he came in with, there's no history of back pain at all. He sounds like he was a very healthy 84-year-old man. So I thought, let's dig in a little bit more about your psychosocial history. So he is home with his family. He's retired. His wife still works. She is a nursing aide in an aged care facility. He's got 2 adult sons that live nearby. Otherwise, everyone's quite fit and healthy. In terms of ADLs, despite his age, he hasn't needed any services at all. And financially, when I stepped into his house, when I talked about his history, he said, "Oh, we're okay. I was an aerospace engineer." I thought, okay, so I think financially he's okay. And there was no evidence of kind of like the flags that we talked about before. He wasn't saying, "We're struggling with money. How am I going to pay for this?" or whatever. He went to a private ED, so he could afford it. And as I said before, his previous employment, he worked as an aerospace engineer, and there's some manual labor involved, but nothing too strenuous to say his employment history might have contributed to his current presentation. Next slide, Carlos. Premorbid function. So he was pretty good. He was independent with all aspects with no aid, and he'll have no restriction in his distance. He's walking around the community comfortably. In his previous exercise capacity, he can walk 1 to 2 kilometers with his wife every 2 days. And he gardens half day on the weekend. He can kneel, he can squat, he can pick up wheelbarrows, but unfortunately not at that current moment. And he can use heavy tools as well. So I guess contrary to some of the patients that we get in ED, he's quiet, his history and his presentation may be different. So I thought this was an interesting case to bring to this kind of forum. So I thought the ED pager wouldn't ring, but it did. I'm sure some of you might have seen something like this. Please review bed 3 for discharge, EDK code, please call this. Don't call that number, that's actually the PJC CRP reception number, it's just an example. So I thought, all right, let's start with, where do you feel what you're complaining of? He said, as you can see on the right, on the body chart, it's predominantly on this, it's all on this right side. It starts from his thigh down to his knee, all the way down to his lateral the lateral border of his foot. So I could see that, you know, it looks like some dermatome distribution, but he specifically said at the back here of my hamstrings. So if we look at the second diagram, the second diagram in the body chart, where it's just the back, just behind the hamstring, that really hurts whenever I take a step. I think, okay, I'll make a mental note. Next slide, Carlos. Let's ask your ags and eases. So he said, well, aggravating is, you know, when I'm stepping on my right leg, it really aggravates the pain all the way up from my foot, all the way up to my hip. And when I'm lying flat, the pain comes. And I said, what makes it feel easier? He said, pain medication, endone works in some degree, but obviously not enough to keep him at home. Seated position really helps me. And being sidetracked, he was actually quite, when you talk to him, you can tell his upbringing is quite wealthy. He's an educated man, and he asks appropriate questions, even questions that really dig deeper into mostly the biomedical side of what's happening. But he did say, when I'm being sidetracked, I actually lose awareness of the pain. So he's got that reflection of you know, deeper than just pain medication. And he also said elevating his leg really helps with the pain. I said, is it worse in the day? Is it worse during night? Is it worse in the morning? He said, there's no real pattern throughout the day. And the distribution, as we saw before from the body chart, you know, it's along the right lateral thigh, knee and shin. It's a constant dilate, about 4 out of 10. But the right hamstring, the proximal hamstring, you know, it's 9 out of 10 when I'm weight bearing. And I did give him kind of like the VAS scale, and I said, you know, 2 out of 10 is when you can feel it. 4 out of 10 is when you can feel it, but it doesn't bother you. 6 out of 10 is when you can feel it, and it changes the way you do things, like, say, you have to use, say, crutches or frames, just to put it into context. So after the subjective, I started my objective assessment. Upon observation, I could see that he was distressed, he was frustrated, and he was really scared of what's going to happen, because, as we said before, he's quite a healthy man. He's never experienced anything like this before, and he kept asking me, what is actually happening? Can you tell me, you know, like, what is actually going on? How long is this going to last? You know, how do I know if I'm going to be progressing in the right direction? And I said, you've only been here for 2 hours. I'm not quite sure yet. Let me dig deeper. However, he wasn't rude or hostile. He was just anxious from my perspective, and just wanted to know. The other thing that's kind of struck me is he had a lot of difficulty describing the nature of the pain. So I was trying to really tease out whether it's mechanical or whether it's nociceptive or neuropathic by using words like sharp, shooting, electric-like. Is it burning? Is it kind of like pins and needles? And he kind of just agrees with a lot of them. So that kind of puts me in a really hard situation, because I'm like, is it nociceptive? Is it neuropathic? And I could see that his right thigh, especially on the hamstrings and the quads, you can see a significant and noticeable difference between the right and the left. And it's moderately swollen from the knees down on both his legs. Next slide, Carlos. So a lot of our job is looking at their mobility status. So of course I looked at his. So lying flat, he said he was one of his ags. He couldn't do any more than 3 seconds. But if you put up the bed mechanics to 30 degrees, it's actually much better. I can tolerate it. If you talk to him, he actually forgets about the pain. You can't actually see that there's pain in his face. Rolling in bed, he needed a mod assist ×1 because he couldn't bring his right leg around. Lie to sit, if you don't use the bed mechanics, it's mod assist ×1 as well. But if you bring it up, he still needs some assistance. Sitting to standing, still needed assistance as well with a 2-wheel frame. But if I try to stand him up without a frame, it's a mod assist. And he weight shifts a lot to the left. Once he's up, he's actually okay. He's got some pain, but the frame's enough to actually keep him moving. And when he's walking, every time he takes a step, he says again that the pain in the back of my leg, that's really painful. And of course, if you've got a painful right leg, you're going to have reduced right stance and reduced left step length, which is what we observed, what I observed. Next slide, Carlos. I remember as a grade 1 when I was at the Anglers, Janet Tam, just like you, Carlos, when I was a grade 1, she said, always check for red flags. So here we are, we're in the red flag section. So I checked his dermatomes, all intact. Myotomes, the only one I couldn't test was L1 and S1 because I couldn't lie him flat or he couldn't single leg heel raise. Everything else is intact. His reflexes is intact, same with his Babinski, and with the red flags on the side, he's got a history of cancer. There's no night pain. There's no kind of saddle paresthesia, incontinence. There is pain, I guess, radiating down below his knee, but I wasn't sure whether it's neuropathic or nociceptive. So I think from looking at that, I thought, his red flags, it's all clear for now. Next slide. So I thought, let's have a look at whether it's mechanical. And I did these tests as much as like he could tolerate. I wanted to know what really kind of bringing his pain. So I did some symptom provocation test. So in the seated position, I just looked at his knee extension and his left. Sorry, that should be right. Right should be 4 plus and 5, and left is 5 out of 5. So the affected side is weaker. But overall, I mean, if you can push through 4 plus out of 5, and he didn't say any pain, then it was actually okay. Resisted knee flexion. With his right leg, again, sorry for that mistake, he was unable to pull his leg all through range. There's no pain in 45 and 90 degrees, but past 90 degrees, it really, so if you're sitting on a chair with your hips and knees level, if any range where his foot is under the chair, that's really painful with resistance. In long sit, which he could tolerate for some reason, resisted dorsiflexion and plantar flexion. Again, the right side is weaker. I know on that slide it says left is weaker. Sorry, that was my mistake, the slides. But it's overall almost the same. Now, this is what I found interesting. I thought in my mind, I started thinking about hamstrings. And I thought, let's have a look at your standing knee flexion. So when he's actually standing on his right side and doing standing left knee flexion, he can do 10 repetitions and he can get to a range of 100 degrees. But if you swap over, so he's on left stance and trying to bring that right foot up, he can only do 3 repetitions and his range is only about 60 degrees. And it's limited because of his hamstring pain. And I pressed it and he jumped in the area that he said it was painful. So I started to formulate a little bit of a kind of diagnosis. So next slide for me, Carlos. So I thought I'd show you this table here about the way I was thinking. So the differential diagnosis that I had from my objective and subjective assessment, I thought perhaps it could be acute soft tissue injury, or it could be from the spine. So why did I think it was an acute soft tissue injury? So there's pain provoking and reduced range repetition in the standing knee flexion. So that last example that we looked at, where the left knee flexion is 10 with 100 degrees, whereas the right one is 3 with 60 degrees. His mode of injury includes a hamstring activity. So I thought about the wheelbarrow, how we picked it up. I'm like, that's pretty similar to like a deadlift, and that's a lot of hamstring activity. Maybe it's a hamstring injury. And then when I pressed on his hamstring origin, so just near the ischial tuberosity, it was really painful for him. Some facts where, might oppose that those factors is, well, the pain extends past just the hamstring, goes to his foot. So perhaps it might not be an acute soft tissue injury. The other thing I thought about is maybe this pain is coming from the spine. It's along the L4, L5S1 distribution. The mode of injury, again, is included loaded lumbar flexion and extension action. So it involves the spine, maybe the disc is involved, maybe there's nerves, and he can't just explain his pain properly. That's why I think it's, nociceptive. I couldn't pave him. I couldn't look at his lumbar range because of his pain. And he's painful in supine. So I thought maybe it's a facet component, or maybe it's a lumbar stenosis because he's much better when he's sitting. I guess looking at the other side of the coin is there's no neurological deficits on the neuro exam that I've completed. So I thought maybe those are, maybe that might be a refutable kind of fact for spinal origin for his diagnosis. Next slide, Carlos. So this is just a reminder for people about the distribution of dermatomes, because sometimes I also forget and there's different kind of versions of it. So this was the version I was looking at. So if you can see the L4, L5, S1 distribution, that's where kind of like where his pain is, right along the lateral side of the foot, leg and foot. Next slide, Carlos. So, true to the SORTEP format, I'm up to my analysis. So I thought, well, obviously he's got reduced mobility secondary to pain in the right lower limb. And perhaps there's a fear-related hyperalgesia component because of his previous kind of questioning to me. It's like, how long is this going to last? Am I going the right direction? What's happened? Tell me specifically. There's just something to consider. That was in the back of my mind. And of course, the risk, there's falls and deconditioning. And those are the strategies that I thought would reduce the risk from all those things from happening. Next slide, Carlos. So the doctor came to me, should I image? And I said, oh, let me just have a think about this. So again, I'm just trying to show you my thought pattern. So what are the factors that, kind of support a yes answer when what are the factors that support a no answer? So for yes, should I, I will suggest imaging. I thought, you know what, well, I couldn't really do a full spinal assessment. So maybe I don't have a complete picture. And I thought, well, if I thought it was a hamstring injury, which was kind of like my contender for a diagnosis, perhaps an ultrasound could be a good idea. And the client is desperate for a pinpointed kind of diagnosis. And I thought maybe this could be kind of a way to explain to him or show him, perhaps if there's nothing wrong there, to reassure him that no biomechanical injury has been done and it's safe to do therapy as tolerated. And the other thing is the client couldn't really describe his pain properly. So I guess in a way I thought maybe my assessment is not as clear as it could be. Some factors that suggest, no, I shouldn't suggest the doctor do some imaging. I thought, well, the red flags are all clear. So we know that it's okay. The neurological exams that I could do is all clear too. And it's unlikely to change its management. But also, maybe we'll wait and see the effect of, pain medication of what it could do. So I said no. They did it anyway. So if you go to the next slide. So they did an X-ray of the pelvis, hip, femur, and knee. And they've practically said that there's no fracture. There is evidence of his, hip resurfacing, a right total hip replacement. Alignment's all good. There's no fracture. They also did an MRI of his lumbar spine, but also all the way just to his, I believe, his hip or his pelvis. So it says in the MRI that, the assessment, there's no abnormal signs with the gluteal muscles, anterior medial, anterior lateral, and posterior compartments of the thigh. There's no abnormal marrow signals noted within the visualized femur or pelvic bones. The neurovascular bundle is all good. There's no sign of muscle tear, hematoma, or collection noted. It's practically said there's nothing wrong with his X-rays and MRIs. Next slide, Carlos. So they tried chucking a few medication at him. So they put him on Plexia 50 milligrams PRN, oxycodone 5 milligrams PRN, and Targen 2.5 milligrams 2 times a day. So this is what I did from a physio perspective. I thought, great, we've got the MRI and X-ray finding, you know, they've done it, might as well explain it to him. So I told him he couldn't really find anything from the MRI and X-ray. The bones are all good, the muscles are all good, the nerves are even good, you know. So it's, you know, I know you're experiencing this pain, and the imaging says otherwise. What we can do at the moment is, you know, we can just do what we can to maintain what you have, and as your body heals, which is usually, you know, if it's muscular, because we know it's not bony. If it's muscular, then perhaps it's, you know, about 2 to 6 weeks before, you know, you might feel a big improvement for your population. Sorry, Janet. Yeah, the MRI didn't include the lumbar, I believe. It was a strange MRI positioning, from what I remember. Yes, Hannah. Yes, that's yes, that's well, he didn't say that it's anything new. Yeah. Sorry, I'll go back to my slides. So just going through education. So I explained the time frame, said the X-ray is all good, MRI is all good. This is what we can do at the moment. This is actually the only thing you can probably do to maintain where you are. He took that pretty well, because I think he really wanted an answer. But I said, well, I've got some answers, but they're not what you're looking for, but here are some answers anyway. And I just try to empower him to do what he can, because what else is he going to do? You know, I didn't quite say it like that, but I said, these are the things that you can do to enhance your recovery. And I educated him just about adequate pain management. I said that you've had an injury. You know, usually we don't take pain medication because we're not injured, but in your state, you are injured. You know, it's okay to take some pain medication. It's already prescribed by the doctors. And we explored other pain modalities. I suggested maybe heat or, you know, ranging exercises. Next slide, Carlos. You know, I looked at what he could tolerate in terms of exercise. So he could do double leg mini squats, double leg sit to stand, and double leg heel raise with no problem. I thought, great, let's just start moving a little bit. And standing right hip flexion, so range and rep as he can tolerate. And standing right knee flexion as well, range and rep as able. So I just gave him those 3 exercises just to give him some power in terms of his recovery, but also a little bit more targeted towards his, you know, perhaps if it is the hamstrings, then perhaps it could, you know, strengthen that. So there's a bit of a spoiler here in number 4. He actually, you know, if we go to the next slide, sorry, Carlos. He actually, you know, despite the pain medication and everything that we did, he had minimal improvement in his mobility. And his wife works part-time, and he still needed assistance with mobility. So he ended up being transferred to an acute ward, and then ended up going to rehab, and actually came full circle, got referred to CRP, and I saw him. So it was quite a nice kind of journey, that for me anyway, to see his progress. I think that's the end of my slides. And I know that there's questions, and Kathy, did it hurt to touch his back? What limited transfers, lumbar movements or legs? Good question. I think at that time, I was a little bit too scared to push his back too much, which in hindsight, you know, perhaps I should have. But from what I remember seeing his transfer, it was his leg, his right leg, that was kind of limiting his lighter sit. Was the patient able to tolerate side lying? Could you palpate in side lying? I can't. It's been a while now. I probably should have done that, but I didn't. From what I remember, lying flat was a little bit too much, and lying in crook, in kind of like the bed with the bed mechanics up, was a little bit too awkward for him. But yeah, thank you for your suggestions for future references.
Okay, thank you so much, Vince, for the case presentation. And the first question to you, what made this difficult for you as a summary?
Yeah, what made this difficult for me? I guess one is, it's not my area of expertise, ED and acute pain. I'm usually in community rehab or rehab. So we'll work more along with kind of like chronic pain. And the other thing that made it really difficult was with his subjective about the nature of the pain, he just agreed with most of the things that I said. So I think it comes with his experience with pain, which by the sounds of it, may not be too much because he sounds like quite a healthy man. So he couldn't describe his pain to me. And that kind of made it hard for me to differentiate. Is it neuropathic, nociceptive? Is it central sensitization? And I think those two factors made it quite difficult. But I think what's funny is, like, despite the difficulty, there's the true principles of physio, like treat what you see, is what I try to do in the education part. And then just a bit of a spoiler, like, this man ended up going home and he did quite well, after his period of rehab, but he still asked us questions about pain. He still tried to dig deeper, where, it really highlights the importance of education. He's gone through acute rehab, and then now, and when he came back to me in CRP, he still had questions about pain. I thought, it kind of reflects perhaps our the time that we spend educating patients about pain, and the nature and the management.
Yeah. So I want to go to some panel discussion topics. So can I ask Tim, are you able to sort of maybe identify some of, like, the key issues that you think that are in this case, how you might sort of start to, problem solve around this case?
Yeah, you have to start with me, Carlos. Thank you. The most sleep deprived of all. Look, I just want to say thanks, Vince. I think it's really hard to present a case like this and be really open to your clinical reasoning and your thinking. It is really complex, and I think the trickiest part is, well, why we're discussing a patient like this is because these patients are really tricky. It's really hard to differentiate between pain in someone's lower back, between someone's pain in their hamstring. Is it referred pain down to their foot from their hamstring, or is it from their back? There's a whole heap of diagnoses that are really tricky. And even now, I'm not sure whether we've come to a conclusion of the problem. I'm also okay with that, though. I don't think we always need to come to a firm diagnosis, despite the patient really, really pushing for a diagnosis. And that's where our education can be really helpful in trying to prevent someone with pain like this becoming more chronic as well. Because wanting to find a diagnosis may limit their recovery. And so that can be really tricky to nail that education. In saying that, although I don't think we always need a firm diagnosis, what we do need to try and do, and I know Janet's got some really amazing thoughts here, is on red flags and what we do need to rule out as diagnoses.
Thanks, Tim. All right, I'm moving to Christine. So key issues, how would you sort of start to work at this?
Hi, everyone. Yeah, I agree with Tim, and also well done, Vince, putting yourself out there. And it is a really tricky case, but like Tim said, that's the nature of these people that come into ED, and we might never know, and it's really annoying, but that is what they are. So I'd be looking to try and work out what is the origin of the pain, if I could try and differentiate between the hamstring and lower back. And again, that's really hard with his positioning and things. And I guess with the imaging, I would have loved it to go a bit higher, just to have a look. But in someone of that age, he's probably got a degree of stenosis and things. So there's a lot at play. Like Tim said, we're trying to exclude anything sinister. And also a big one with this guy, seems as though he's quite anxious and really sort of asking a lot of questions, all that sort of thing, is to manage his beliefs and manage his education to set him up for a good recovery, because people who feel dismissed are probably just going to put you on the back burner and go to the next person. So I think you really need to, although we don't have the answers and it's really hard to address that, try and give them something to move forward with.
I think, can I just add, like, Christine, your last point, although he had so many, questions, when I said, look, I'm going to be honest, these are the x-rays, these are the MRIs, it says that it's okay. I'm not quite sure what's happening. I have a theory. let's try it out. This could be one of the things, you know, with physio, we hypothesize, we try one thing. If it doesn't work, we go back to the drawing board. And he actually took that really well. And he said, well, you know, thanks for letting me know. I'm happy to give it a shot because what else can I do? And I said, okay, well, that's good. And, you know, I think it was just surprising, especially when he came in so anxious, full of questions, and he didn't get the answer that he wanted in a term of in the form of a medical terminology. But he was happy with that answer. Yeah.
Leanne's just written, consider the value versus the harm of pathoanatomical diagnosis in acute presentation. So telling the patient they have they've sprained their back is the best and most accurate diagnosis we can give and can normalize expectations of the recovery. I think, yeah, one of the things that I really like to sort of say is, you know, this is the time period of acute. This is what you need to do, and then after this time period, then we can start doing something else. So the diagnosis is sort of less of a, you know, this is a life sentence sort of thing as well. Janet, can I ask you about just making some comments about the key issues, and then maybe starting to talk a little bit about the clinical examination, how you would have approached the clinical examination in an ED setting?
Yeah, okay. I can't see myself, but I think you can hear me right. Okay. I guess I'm just sharing my thought as a clinician. I have an interest in this area, and I see things slightly differently to what Vince has presented. I think I probably want to sort of like put in a little bit of a risk hierarchy. Okay, looking at this particular case, the actual distribution of pain, I would be focusing more on spinal. Okay, in terms of hierarchy, I would assess lumbar and spinal first, because hamstring or proximal local problem is unlikely to radiate to lateral side of the foot. Okay, the second thing I want to really put an emphasis on is what we call clearing the red flag. I don't think in this case we have cleared the red flags. The age being 84, the mechanism being a forced extension from a fixed position, it in itself, you need to clear an insufficiency fracture, osteoporotic type of fracture. So I look at this quite differently in the sense that risk mitigation, red flag need to be clear. Clearing red flag include in this age group a consideration of the broad breadth of possibility, which obviously include whether there would be a likelihood of insufficiency in osteoporotic type of fracture. Yeah. So in that regard, like in terms of assessment, I think your subjective inform your objective then inform your management. Okay. The subjective, we need to be properly identifying like the actual aggravation. So the patient mentioned that any weight bearing really, isn't it? Stepping onto the foot. So which could be like, it could still be spinal. And if you have not assessed spinal movement, you have not touched the spine, and purely a neurological being okay does not mean like you actually assessed the spinal component of it adequately. In terms of like approaches of like of differentially diagnosing, okay, I normally in my mind I try to hypothesize as I go. So therefore, on the distribution of the pain, I will be hypothesizing that I need to assess lumbar. All right, what other area can contribute pain to the area? Then you work down your list. Okay, obviously, like Vince said, like if the main pain is in the upper hamstring, okay, local soft tissue can be one of it, but it wouldn't be my highest hierarchy. But whatever you decide based on your clinical reasoning of the subjective, then you systematically work it out. Meaning, my highest risk and highest suspicion is lumbar refer pain. Okay, so therefore I assess lumbar movement, I assess palpation, and I reason enough whether at this age group with that mechanism of injury warrants an X-ray as a base level to assess the clinical risk. If then I'm satisfied that it does not actually match my hypothesis, then you have to actually look at what other possibility is there and test your hypothesis. So like as you go. So for people who are in a lot of pain, it doesn't mean that you can't assess. The fact that they can't move is in itself a valuable assessment. And simple things like if you do ask them to do a rotation, this person is comfortable in sitting, and you compare rotation in standing. Okay, that gives you valuable information as well as to whether the compression itself by just standing make a big difference. Yeah, so being in a lot of pain probably does not negate the fact that you can assess that area. Yeah, I guess we can go into a little bit more detail of different parts, but I think the main thing that stands out for me is that I would look at this case more as a spinal, and I would not actually feel like I'm comfortable with the red flag being clear until I actually know that there is no suspicion of a osteoporotic type of fracture.
Yeah, it's really good, because I feel like the way that that Vince sort of presented the red flags was he did a neurological, which is like an objective way of determining whether there are red flags, and you know, the neurological examination was negative, but what Janet was sort of saying as well is that the subjective aspect of the fact that it's, you know, first time back pain, 84-year-old, and other subjectives may lead you to be more of, my gosh, you know, red flags, let's be more pro investigations so that it actually excludes our red flags. I want to go back to each of the panelists again about what would you add to the subjective and what would you add to the objective? And I'll ask Christine this first, so Tim is not first. What would you add to the subjective that would probably lead you to, you know, be more comfortable and, you know, have a bit more of an idea about, you know, the differential diagnosis as well as, you know, where to go with this person?
So we've got the details about the mechanism of injury. I would have liked to know what he felt straight away. So I guess if you're looking at a hamstring tear, you'd expect that to be instant pain and instantly limiting. And looking at from what Vince has said, it sounds like it kind of increased over a few days, which I'd probably be with Janet. That is more common with a lumbar diagnosis. Sorry, what else did you say, Carlos, in terms of your assessment as well?
Yeah, I think that you would add.
Yeah, I'm just looking at dermatomes, just reflecting on what dermatomes can tell us. So we know that they're giving us that cutaneous innervation and what spinal levels they come from. But when they've done studies jabbing lumbar discs and things, the representation of pain is not quite as specific as those dermatomal lines. It'd be nice, but it's more vaguely down the back of the leg and down the front. So I guess whilst it's helpful, we don't want to align specifically with that as well. It would have been perhaps useful if he's comfortable sitting to, and again, it might have hurt if it was a hamstring strain as well, but a slump kind of in sitting as opposed to a straight leg raise might have been good. And I guess going through all those, the other red flag discussions about that Vince has cleared. With the cauda equina, Vince mentioned that you know, he wasn't having any bladder or bowel symptoms or saddle symptoms. I think it's good to ask, you know, they've decided that actually bilateral leg weakness is most specific to cauda equina syndrome, and having difficulty starting to void. So they're quite specific questions. I think it can be when you say, have you had any troubles with your bladder or bowel, people often assume, have you had a UTI or have you been constipated or anything? So it's good to dig into that a little bit more perhaps. But yeah, tricky patient.
Good one. Thank you. Tim?
Yeah, thanks. I think I would be wanting for some clarification around the referral pattern. Vince, you mentioned that he's getting some foot pain as well, or some referral to his foot. And I guess I'd be wanting to work that out a bit more and try and work out if there's a movement that's causing that, or is it more constant, or is it more intermittent? But also very much keeping in the front of my mind what Christine said about where dermatomes refer to can be quite vague and broad and hard to pin down as well. So I'm conscious of it, but I'm not tying myself to that single piece of information either. The other thing I also want to find out from him, and this kind of feeds into my management as well, or how I'm guiding imaging, is judging whether the patient is going to be receptive to hearing about the evidence around the imaging as well. And this is what I'm trying to suss out the whole time in my whole interaction with the patient. Is I'm trying to find out, are they going to be on board with hearing about evidence around imaging, or is that kind of a decision that we might just take away from him a little bit? How much is he going to be on board with, let's say he does get imaged, how receptive he's going to be, dispelling some myths perhaps around the links between imaging and his pain. And also me trying to work out just how much information you can take on board as well when it comes to pain education. Is he going to be on board with me, perhaps talking about the pain is really driven from our brain. And some people are really open and receptive to hearing that in ED, and they can get I've had really great success with them once they take on board that information, kind of moving on and being, okay, cool, I feel safe to move. But he may not be at that point. So that's something I'm trying to suss out during my assessment as well. When it comes to my objective, something I'm conscious of is I'm trying to balance the detail of my objective, especially with the palpation, to try and not spark panic with him either. I'm trying to be specific, I'm trying to be precise, but I'm trying not to make it go on too long, or I'm trying not to act too surprised with anything I find out from my objective, because I want to try and convey a lot of reassurance from the get-go, even in my assessment, and trying not to show any worry that I've got to him. If I do palpate something in his back, he's coming with back pain primarily and hamstring pain, so I'm going to touch something that's going to be sore, and that's to be expected. And so probably somewhere in his back it's going to be sore, but trying to reassure him that I haven't found the one sole source of pain. And that's kind of more about how I'm going to communicate my assessment to him.
Can I add to that, Tim? I think that's a really good point. Just about, we're brought up, and as physios, we're trying to find the danger. We're trying to find what's bad, but it's really helpful for the patient to comment on what's good. So, you're moving their feet and say, oh, yep, that strength is really good in that foot. That's good. And you're just kind of having that sort of language as well. And the other thing that I forgot to mention in subjective wise would be to ask him, does he have any beliefs of, does he have any idea of what might be going on? What does he think might be happening? Or does he have any worries about what might be happening? Maybe his brother died of cancer that had spread to his back a year ago, that there's reasons. And if you can move those worries aside, you might then have a clear run if that's what's limiting him.
Mm-hmm.
Yeah, I'm just going to add on to that, Christine. I think this is a bit of having a panel, kind of two parts. You mentioned the brother with cancer. Also, Uncle Jim at the family barbecue, who's had back pain his whole life and now walks around with a stick and hobbles around. I guess in this context, this guy's 85. But let's say someone was in their 20s. I often hear you ask that question. They go, "Yeah, I've got a family member who's battled back pain their whole life," and I go, we're not expecting you to go down this path. It's a rare path to go down, so trying to reassure them there. You talked about, as physios, we're kind of trained and brought up to try and come to a pathoanatomical diagnosis or something really specific, and Leanne kind of talked about that as well in the chat. I think it's something as physiotherapists, we have to try and be comfortable with sitting with some level of unknown, that we don't have to solve everything. We don't have to find everything out. And that can be uncomfortable for some people, but kind of being confident that in the context of back pain, non-specific low back pain is a diagnosis. It's a thing that we can work with here.
Thank you. All right, too much in between talk between you guys. Janet, Janet, do you want to make a comment about what you would add from subjective and an objective perspective?
Yeah, I'm not sure it's already covered. In terms of subjective examination, I would probably be interested and curious to know where is the main pain. So based on the body chart, everything is same kind of density and distribution. So I'm not clear where is the main pain and why does it matter? Because like if it's more like leg pain more than hamstring pain, it can be sort of like a helpful hint in differentiating different structures or things that we can actually deal with. And in the subjective, I think, or in the objective, I think Christine has mentioned about a slump. I would actually be slightly in a different mindset that I think in people in that level of irritability, I would not, I would not do a slump on day one, okay? If I am, my hypothesis is that there is significant like neurotension, it would have revealed itself in a straight leg raise. And if that's not adequate, I can add slight neck flexion to increase it or use the bias to increase it. I don't need to actually, I think slump is out for me on day one examination on irritable back pain. And I would probably objectively do quite a bit more or explore a bit more what I call symptom modification test. Can I make it better? So it's like, first of all, we probably need to find something called a objective asterisk. What brings on the pain, which is a level of pain that you actually as a therapist can deal with. So you're not wanting to put people in an agony, okay? Say, hypothetically, if this person, this old gentleman, maybe cannot side flex or flex to a certain point, can only probably in standing, if hypothetically, okay, reach the knee, all right? So what if I actually change certain thing, either muscle tension or in my hypothesis that it is coming from lumbar, if I offload the lumbar segment, can the movement and the pain change? That only takes 5 seconds in part of your assessment, okay? So in terms of assessment, I would be thinking along the line of, I do it systematically. In lumbar, I would do the movement, I would do like the basic, so like neurologic and neuro test to neuro examination to clear the neurological side of things. I would do a basic straight leg raise to assess neurotension. I would do a palpation in this case, not to provoke a lot of pain, but if it is a insufficiency fracture, it will be very, very locally tender at one point. And that's important. Yeah. And I will test mobility, all right, for a basic level. And during that test, if I found something that is sore but is bearable, I try to add a few seconds of test to see whether I can modulate the pain. And that then inform my treatment as well. And it helped to support or not support my hypothesis, then I can move on to the next one. So nothing changed, okay? What other things can be modulated or changed, or what's my next part to help the patient and clear the picture a little bit for myself, yeah.
That's great. I think, thanks guys. You know, like in chat, people talking about irritability, making sure that we manage our objective examination such that we are supporting irritability. I really love like Janet's, you know, snag sort of thing where we let's say that the objective asterisk, objective asterisk was sitting sort of knee extension that didn't cause too much pain. Supine straight leg raise was a bit of a problem. Our normal straight leg raise is in a supine position. What you could potentially be doing is modify it such that you're controlling more of the position. Maybe you choose side lying and then you try to replicate a straight leg raise. Let's say that causes a little bit of pain. And what Janet would do is do a snag, like a mulligan snag. I probably would also go and do something like quite significant where I would be doing something like, okay, what if, like, for example, if I noticed that they had a lot of like abdominal tension, core stability stuff, or if they had little abdominal tension, what I would do is I would get them to do an abdominal contraction and then repeat that examination and see if that's made a change. And that will help to support where I'm going to go with this person. So if, for example, they improve with like an activation of their tummy, right? What does that mean? That, the active system can support the recovery of this person and their pain. And that's also really supportive of someone to go, wow, that made a difference. That makes their, risk of chronicity a little bit different. I want to just move to, or actually just by, so other things that you could potentially do is do traction, maybe do repeated something, like for example, like repeated flexion extension, but that is actually quite irritable. Janet, any other additional things that you would add?
I think it's the concept, like you need to respect the irritability, but it's the concept that you, in your assessment, you can assess your hypothesis using maybe a few seconds of additional things. Say, for example, in this case, Vince believed that the clinical sign point towards a possible hamstring. So what if I shorten the hamstring? Okay, if I believe that, okay, I tape to shorten it, or I change the patient's position and shorten what was painful, and would that weight-bearing pain change? So you are able to not needing very lengthy addition to your test to give yourself some additional information to support your hypothesis or to negate your hypothesis, and that also drive your management approach as well. So it's all step by step based on what you see clinically, and formulating your step from one to the other.
Yeah, I think we can talk about this a lot. We are running out of time. But what I do want to do is just maybe just get one or two of you guys to comment about investigations, and just have it as a very, very short thing, what would you do in this sense and why? Investigations wise, maybe Tim.
Yeah, thanks, Carlos. Janet's already touched on that X-ray would be really important in this age group, and we've got a few red flags, and we want to rule out an insufficiency fracture. I wouldn't go down the path of doing any more imaging other than that. I don't think we should be aiming for diagnostic imaging at this point in time. So even though the patient's really pushing for imaging or a diagnosis, I don't think we need to. I don't think it's going to be helpful, and it could be harmful.
Perfecto. Thank you, guys. All right. Well, what I'm going to do is I'm going to stop sharing, and then can I ask everyone to have maybe a 4-minute break? And then what we're going to do is we're going to set up for our second case presentation. Thank you very much to the first case presenters and panelists. That was an excellent discussion. Well done to you. All right, so we're going to be back in 4 minutes exactly. So have a bit of a stretch, and then we'll get the show on the road with regards to the second case presentation.
Hey, Carlos, who shall I spot?
So we have Andrew, Andrew Rank, we've got Hannah, Linda,
yep,
and Kathy. Yes, also, please don't forget to complete the evaluation form, please do it truthfully. Don't do it just because you like everyone that's on the panel. Thanks, Karen, and thanks for contributing as well. Evaluation form, please do it.
Everyone will need to complete at the end because we're going to ask questions about the second case and the final presentation as well. But yes, please complete before you exit today.
I've lost the ability to spotlight.
What happened there?
I don't know. I can pin.
Maybe it's because we've got too many people spotlighted.
No, I've taken all the spotlights off.
Oh.
Yarra Ranger CRP will let you in when you're in the waiting room. Noted.
Okay, let me spotlight Pete.
Oh, you can do it. Okay, great.
Linda.
Sorry, my role is redundant.
And spotlight. They were already spotlighted, I think.
Yeah. Now they're spotlighted. You've got 4 and you want to spotlight yourself. Yep, there you go.
Can you let me into Zoom?
It's my personal mobile. Yep.
No problems. Anything for you, winner. That's Ping, by the way. Well done, Ping. You absolutely smashed that.
Yeah, I loved it.
Catastrophizing is a big one that nobody really ever gets. Oh, you're the person that organized that, Renita, is Leanne.
That's typical.
Typical, exactly. All
Leanne
right.
did an excellent job at the whole thing. Maybe Leanne can tell us like what Yarra Rangers peeps will do.
I wonder if Healesville's an option.
What about my house? Is my house like an option?
Yeah, what OH&S hazards have you got there, Carlos? Maybe too many plants?
I hammered myself doing a hobby propagation station. I'll just show you this.
Oh, that's beautiful.
It's so funny actually because I hammered my right thenar eminence, and then while I was in Bikram yoga, I started developing like this mirror pain on my left thenar eminence, and I was like, uh-oh, I've got issues. Okay, I think we should make a start. So I will share screen again. We'll go onto this beautiful heading slide, and I will introduce the next sort of peeps. So we've got Andrew Rank, who's going to be providing us with case presentation number 2. So Andrew is, thank you very much for being here. He's a grade 2 physio, CRP, and Waterno Health in the MUSC stream. He has completed the Bachelor of Physiotherapy at Monash, and he's currently enrolled in the Masters of Musculoskeletal Physio in La Trobe. Special interests are rehab, MUSC injuries, strength training for older adults. We have Hannah. Hannah Sharma is grade 3 physio and the team leader of the PJC subacute stream, previously in the chronic pain team of Caulfield. She is a bachelor in physio with La Trobe, special interest in chronic pain, perfect. We have Linda Wobbling, grade 2 physio, Yarra Rangers. Don't forget, Yarra Rangers does exist too, CRP and cardiac rehab. Bachelor of Physiotherapy with honours, Melbourne University. Special interest in the management of complex musculoskeletal, lower back pain and cardiac rehab. And last but not least, Catherine Sanseric, grade 4 clinical lead, aged and complex care for Anglis, PJC, Maroondah, TCP. She's a 30-year graduate La Trobe and has done her Musk Masters at Melbourne Uni. Special interest is aquatic physio, amputees, Musk, mixed complex care, mental health, disability. It is such a pleasure to have you guys here. And with that, I will hand over to Andrew to start his case presentation.
Thank you, Carlos. Well done, everyone, for still being here after 5 o'clock. Can you jump to the next slide, please? Thank you. So this is a 53-year-old lady who's referred to see me in CRP after she was admitted to Box Hill with low back and leg pain. So if we go to the next one. So we'll see that she was at home cleaning her house. And during that activity, she developed just some mild pain in her low back, which then gradually worsened over a period of about 3 days. And then she eventually took herself off to hospital when it was radiating down her leg and she was having trouble walking. So then she was in Box Hill for 10 days. From the doctor's side of things, they had a go at analgesia. They did some investigations. She shared a CT of her lumbar spine. And also because she was complaining of abdominal pain, she had a CT abdo as well. And she was also referred to psychology because of concerns around her low mood. And then on the physio side of things, she had a spinal assessment in ED, and then she was seen 3 times on the ward, more around mobility, progression, and discharge planning. And then if we jump to the next slide, we'll see that she was then referred to CRP. And at that stage, she was independent nil aids from the EMR dispatch summary there, and she had some nice clear goals. She was referred to CRP to get back to gardening and to be able to access the community again. So the next slide is just her past medical history. So on the left, you can see that she had type 2 diabetes, which she controlled with diet. And she did have a history of struggling to control that at times. She had obesity, so I think her BMI was about 37, and she'd had previous gastric band surgery, and she also had high blood pressure, and she also had a mental health history. So she had post-traumatic stress disorder, diagnosed anxiety and depression. In terms of her low back, she'd had problems with low back pain over the last number of years. So the first sort of main episode was in 2010. She was doing some renos at home. Had a big flare. She was admitted to Box Hill at the time, and she had some imaging, and she was managed for a disc prolapse. She had a steroid injection and spent some time in rehab, and then she'd been able to get on top of it at times over the next years, but still did have some difficulties. The kind of person that would say that she had a bad back. Psychosocial history. So she lived at home with her daughter, who was in her 20s, and she acted as the primary carer for her daughter, who had a number of her own health conditions. So you can see she had some heart problems, and she'd also had quite a recent diagnosis of bipolar disorder, which was a big stressor for the client. She hadn't worked since that first time she had low back pain nearly 10 years ago. And she said that she'd recently, in the few months before the admission, she'd applied for the DSP, and there was some stress around that. Not a lot of great social support. So she was estranged from her mother and her sisters, and she had a history of adverse child experiences and family violence, both at the hand of her father, and also the father of her daughter had been a perpetrator as well. In terms of managing her mental health history, she'd been linked in with a psychiatrist for a long time, wasn't actively seeing them at the time I was seeing her, and she'd previously been linked in with a psychologist in the community who she'd also stopped seeing, and then also a number of community mental health programs that I wasn't that aware of, but had been more around the support and services side of things, but she dropped out of those as well. In terms of finances, she was struggling, having not worked for a long time. She could get the carer allowance for her daughter, and she was on JobSeeker. And she was awaiting that DSP application. Prior to the admission, walked unaided, completely independent, drove, liked to get out in the garden, but not regularly into exercise, relatively sedentary, not someone that would go to the gym or go for a walk for leisure or anything like that. Thank you. In terms of managing her sort of more persistent symptoms with her back, she saw a chiro sometimes, and she found that manual therapy and massage helped get on top of things if they flared up. Quite a number of years ago, she'd been through a pain management program, I think, through another network. And she'd previously been on opioids following that first admission, but had been managed to come off and wasn't on anything for the last few years. She had seen a couple of physios before and seen a few people that had talked to her about exercise, and she'd tried a few different things, but nothing that she really enjoyed or been able to sustain. So when I saw her, these were the symptoms that she was describing. So she had quite a diffuse band of pain across her lumbar spine, radiated into her left lower limb, but also across into her right groin. And she she wasn't able to describe it too well, or I wasn't able to get her to describe it too well, but she did describe it as an ache. And the next slide's her pain behavior. So really any movement was the aggravating factor. So pretty much anything that I asked her to do, or that she would talk about doing or would think about doing, would aggravate it. Flexion, definitely worse than extension. No notable eases other than just being still and resting. And then in terms of 24-hour activity, there wasn't really a clear pattern other than just it was worse when she moved around. And we talked about sleep. She's generally a really poor sleeper, so generally only averaged sort of 3 or 4 hours a night, and quite interrupted, but it wasn't specifically related to her pain. That was something that she'd been dealing with almost her whole life. So I said they did a CT lumbar spine at Box Hill, which was essentially normal. So there wasn't anything on there that was worrying or really fit significantly with her picture. And the other investigations were normal as well. So she had some bloods done. And then in terms of her abdo pain, she had a CT abdo, and that was normal. And then by the time I saw her, she never reported that again. We didn't discuss it, I don't think. She was prescribed Lyrica, so she was still taking that a couple of times a day when I was seeing her, and that was new for her. And she'd just been prescribed tramadol to take as she needed in the hospital, but wasn't using it and didn't want to use it. She'd had a few years of trying to wean off opioids a number of years ago and wasn't keen to start anything like that again. And there was no other history of alcohol use or smoking. She's a non-smoker, or any recreational drug use. So she was patiently waiting for me at Knox Pathology for her first appointment. So she was a little bit late, but by the time we found her and she came across, there wasn't a heap of time left for a lot that session. But the things I noted were that she was really slow and cautious to move. A lot of outward kind of expressions of pain, so really grimacing, a lot of facial expression, and she moved really slowly, and she was quite flat affect and quite quietly spoken. So the first session, because we didn't have a lot of time, was really just going over our history and talking about what we might do the next couple and trying to be reassuring. And then these are sort of the main breakdown of the objective findings. So she had restriction, mostly in lumbar flexion, and she really didn't like moving very much at all, but particularly into lumbar flexion. So flexion to her knees, tentative and painful. Her other movements were slow and cautious, but not overly restricted. Her passive straight leg raise was painful, but not concerning, I didn't think. And then in terms of her strength, again, she sort of had general weakness throughout her lower limbs, but nothing focal or that sprung out as worrying from a neurological side of things. And then in terms of palpation, really hypersensitive, just on very light touch, pretty much throughout her whole lumbar region and through her glutes as well. And during our appointments and going through testing, the main things she really wanted to talk about were everything that was going on in her life, really. So she was really struggling trying to manage the care needs of her daughter, and she was finding that the patient with her own sort of appointments related to her hospital admission, and also what was going on with her mental health, trying to juggle that was really challenging, under a lot of financial stress, and just really not coping. And we talked about poor sleep already as well. So when I asked her what she thought was going on, she said there was a disc pressing on her nerve, and she carried that forward from the scans and the work she'd had done a number of years ago. We talked a little bit about the scan she'd had this time, and her response to that was that a doctor had told her that you just couldn't see it on that one. But she wasn't super fixated on that, and asking her what she wanted to do, she wanted to get back to how she was before. And she said she could manage with some pain because she'd had pain for a number of years, and she just wanted to get back to what she was doing. And then this is just an excerpt from the care plan that we do with everyone in CRP. So issues in her words or shared words, and then the goals that we're working on. So getting her back out in the garden and to being able to walk far enough that she could get around the supermarket. So I just broke some of that down into the flags. So she's got the orange flags there of the diagnosed mental health disorders, the yellow flags there that I sort of pulled out, as you can see, and then the blue and black around her sort of social isolation, her loss of contact with work, and then the financial stresses that we discussed as well. And this is straight from my CPF notes. It's a little bit scary putting your thinking in front of the whole physio department. So my analysis is that she's a 52-year-old lady with an acute flare of persistent low back pain with associated lower limb symptoms. And then I felt like she had a primarily nociplastic pain type, so lots of features of central sensitization, and then the potential drivers to that I've listed there. So some more nociceptive ones, some more of the psychosocial ones, and then around her psychiatric history and some of those metabolic factors as well. And then I just added on, potentially missed out a little bit in my own analysis of some of the more mechanical type things. And that was sort of coming out of when we were talking about it as a panel and with Carlos, looking back and reflecting on it, maybe I'd started going down a psychosocial path, maybe slightly too early, but maybe the panel might pull that apart a little bit. And then the next slide, I just tried to just overlay that with the pain and movement reasoning model. So the local stimulation section, potentially a number of nociceptive sources. So I don't think I was really able to find a specific tissue diagnosis for her. So I think, you know, I'd be comfortable saying that she had a non-specific presentation, but a number of things that might be nociceptive, and then occurring within the context of those other CNS and regional modulators that we talked about before. So this is what I did. So pain education is definitely a skill in development for me. So trying to go through some of the factors specific to her with her, and she was quite interesting. She had a really good awareness of, like I've said there, awareness of the links with her own cognitions and emotions. And she was really able to recognize that if her mood was bad, her pain was bad, and those sorts of things. And we got her moving, so some graded exposure exercises. So got her doing some things into flexion, mimicking some things she might need to do in the garden. She was doing pretty well with those, so was able to add even a little bit of load, doing almost like a dumbbell deadlift or a pickup. And then also a general conditioning program. So we worked on sort of setting a baseline for trying to get her to do some walking. She didn't do as well with that, or we didn't do as well with that. But she was doing a little bit more moving generally, and she looked a little bit better in terms of her movements too. And then we spent a lot of time talking about the psychosocial stuff with her. So I was just trying to get my head around what support she'd had before, and what supports it sort of felt like she needed, and what was available, and tried to bridge the gap there. So she started seeing her clinical psychologist again, which was good. She'd been previously involved with some of those mental health sort of support service, community service programs, but she didn't really find them helpful, and she didn't want to try those again. Spoke to social work about her in CRP, but she wasn't keen to get in touch with anyone else. And we had a brief touch on NDIS, and she'd spoken to her psychiatrist before about NDIS in regards to her psychiatric diagnoses, but it wasn't something that she wanted to look at for herself, and she'd had negative experiences as the carer for her daughter. So she was going pretty good. The first few sessions, I was feeling pretty good about myself. She was getting back to doing things, and it seemed like things were working. And then she started fluctuating. So whereas before she'd been coming and had made a few gains, now it was more like she had, she'd identified a new problem, or she developed a new problem. So she had a sore elbow today. What's going on? I've got a really bad migraine, or she had really widespread pain or super fatigued, and her mood was tied in with that really heavily. And then she missed quite a few appointments due to various reasons, and some of the stresses with her daughter were getting a little bit stronger at that stage. And then after sort of several weeks of not making a lot of change and it being quite interrupted, we agreed that it probably wasn't the best time for her. CRP can be a bit challenging if people aren't progressing linearly. So yeah, we agreed that it probably would be best at that point to discharge, and I gave her some info about other things she might be able to try in the future. I sent a discharge letter to her GP and a few other different programs as well. I think that's it from me. Do you want me to jump straight to what made this case difficult, Carlos?
Yeah, go for it. Go for it.
So there's a couple of things. I think the first one, I was concerned about her mental health in the first instance, about her safety, and we sort of addressed that early. But then the other side of that was sort of recognizing that there were potentially all of those like psychological and social problems, and then exactly what one of the comments in the in your thematic analysis was. I was laughing, Carlos. It was like, but what do I do with this? So recognizing all those things, but then still needing to try to work with her and treat her anyway alongside those, because PTSD and severe anxiety and depression weren't things that were going to go away. So trying to work alongside those, I think I found really challenging. And then the other thing I found challenging was, it was all fine when we were getting better and that was good, but then when she started fluctuating and there were new problems, and she might be doing really well one time and then really not well the next time, I think that's something I find challenging with lots of my patients. So trying to manage those fluctuations, I think I always try to recognize that people have setbacks and warn people that they'll have setbacks, but then we actually have setbacks. Trying to deal with that, I think, is tricky.
Yeah, thank you. I'll ask the panel in a second to make some comments about that with regards to their key issues and how they would have managed it. But I just want to say, it says in the chat, there's a lot of people that have been saying that they love your analysis, that they think you're the best, one of the best analysis blurbs. So thank you very much for providing that, and thank you for putting some of the concepts that we've introduced in your case presentation. One of the things when we did mock it that I had mentioned was, I was like, dude, how did you get so good at tell us about how you got to the point where you were able to really tease out all of the psychosocial stuff, and your answer wasn't amazing, but do you want to just tell us about the answer?
Well, I think I said she just told me all of it. I think she was a bit different to some other people I've worked with, and that she was not keen to share, but willing to share with a couple of questions. Yeah, so for her it was just about listening, and she said it all.
Yeah, I think that that was not the best answer, but I guess that what it was really was that you got everything. You were able to really complete that triangle, and I thought that was really fantastic. The others, when we mocked this, were really impressive. Thanks so much of that. So I want to go to the panelists. I want to start with Linda, actually. Somebody is using like some sort of like drawing tool on the slides. I don't know who that is. It might be Leanne, and I might relinquish co-host from her because she's making a mess of our case presentation. Anyway, so I want to ask Linda, what did you see as like the key issues here? How would you have managed this person yourself?
Yeah, look, first of all, I think Andrew did a great job. I think, certainly I think we're lucky in CRP that we have time to spend with clients to do a really lovely, thorough assessment. And, particularly with the current sort of scenario in the hospital system, people are rushed through, and I think to sit and listen and to validate someone who's going through all those stresses can be a really good starting point, even if you don't get to the objective and the, the diagnosis or whatever. So, yeah, I think that's obviously a really, that jumped out as a key point for me. Yeah, it was obviously sort of challenging with all those sort of psychosocial factors. And I guess, that's where, making sure that we still do that sort of thorough analysis and an assessment to make sure that we can give the client the right sort of feedback and give them a direction for their treatment.
Cool, thank you. Hannah, same question to you.
Yeah, same question to me. But first of all, congratulations, Andrew. You've done a great presentation. And I realized that you mentioned that it is a little bit daunting to put your clinical reasoning in front of the entire department. You know what is more daunting? Is to put your impressions on somebody who has already been recognized for amazing analysis. So I share that ground with you there. I guess in terms of when we did first have our mock practice session, extreme reflection on Andrew's, extremely good reflection on Andrew's part to say, okay, well, this is something that I may have missed out on. And that is the first thing that comes to my mind when I always, anytime see somebody who's been coming in with persistent pain is, can I with 100% confidence say that the red flags are really nil? And what are some of the things that are telling me that the red flags are really nil? So yes, there might be no primary injury acutely that might have happened with this person, but are there any secondary factors because of the fact that she's been living with persistent pain and fluctuating symptoms, which are leading to things like tightness or altered biomechanically advantaged or disadvantaged length tension relationships? Or are there any problems with the neurodynamics that I kind of clear out first? And then like you did reflect that quite often we do jump onto the psychosocial aspects quite quickly, which is extremely important in this situation to have an understanding of. But then there is this niche area about physio that only physio can do very well, which you have kind of approached and touched upon in terms of your lumbar examination and trying to relate the ags and eases to the presentation, and maybe how your treatment is being affected secondary to that. So really good clinical reasoning there. The other key issues in terms of her psychosocial, and I used to do that when I was first started to see people with persistent pain, was, yes, I know that this person does have post-traumatic stress disorder. And I used to feel really proud by recognizing it and sending them to see their clinical psychologist again without realizing that one of their issues is managing appointments and running up after appointment after appointment after appointment. So what is going to be helpful versus what is going to cause their daily routine or their weekly or monthly routine for that matter, make it a bit more hectic. I did make some notes in terms of that. Yeah, and I mean, in terms of fluctuating symptoms, like you said, they did actually fluctuate not only within the one area of the body, but across the areas of the body, like tendinitis. And what is that telling me? Is that telling me that there is some issue in that biomechanical chain, which can be fixed with the functional approach, which is what you were trying to do intuitively anyway. But I think it's helpful to have that reasoning spoken out loud for other people and for future. So that's kind of my take onto.
Thanks, Hannah. And just on that as well, I wanted to say as well, it's like, you know, the fact that the pain is sort of changing and fluctuating, it may mean that it's, you know, it may provide you with, oh, you know, is this central sensitization? But you should also go, is this red flags? Like, is this rheumatoid arthritis, or is this, you know, some sort of other systemic disease that that could be affecting it? And back to those slides, you know, all of them all of those psychosocial things that we had in Jeopardy, in our Jeopardy game, has widespread body pain. I want to move to Kathy. So Kathy, key issues, how would you approach this person?
Hi, amazing job Andrew did at his stage. I agree with what everyone said, but once I feel like we'd ruled out anything major, the main thing was that this lady didn't believe it was dangerous to move, because it was very clear in that slide that she equated movement to pain and rest with relieving the pain. So I'd want to address that belief. The second thing is, if I couldn't find anything mechanical that I could fix quickly, I have to chat about, this is not a quick fix. You've had so many episodes and there's so much going on in your life. It's the readiness for change. I don't think she's in the spot at the moment that she's ready to do the things we know will help her. And there's no rush if there's nothing serious going on. Let her address everything and then come back to us. And that happens, and that's okay.
That's brilliant. Can I ask you about, because you said quick fix, can you tell me a little bit more about that, like how that works?
So a bit like what Janet was talking about, if I find something mechanical or I try a mini treatment and it works, I say, I can do this, this and this for you, and that'll give you some relief for a little while. You can start to move around and see that it's nothing serious and that you're going to get better. But if it's really truly non-specific, you know, it's looking at the whole person. And I think I was going to say in one of the other questions, her sugars being up and down, her diet and her lack of exercise will all be driving these repeated episodes.
So motivational interviewing was something that Tanya has written in the comments, and we have actually talked about this in our mock. Maybe I can ask Linda about, you know, how would you approach this person's motivation? Like, is this sort of like something that you kind of go, that you have a conversation with them and just go, look, it doesn't seem like you're ready, let's just move on? Or is it sort of something that you give a go at, you know, getting their motivation, getting their buy-in maybe?
Yeah, look, I think it's something you start gradually and certainly building that rapport and validation of where they're at first to sort of start that conversation so it flows naturally. I mean, I'm thinking about some of the clients that I see and sometimes using a sort of a functional assessment like a 6-minute walk test to sort of show them what they can do as well. You know, oh, you achieved this sort of this amount with this walk, you know, you're able to walk 300 meters. Look, that could be a good starting point for you to sort of, you know, start doing some walking, and this is what you can do rather than this is what you can't, and sort of starting that, then that, you know, if they're ready, that conversation around the importance of exercise for their back, but also for their mood and their diabetes and everything, so that you know, but again, that I guess with that motivational interviewing, it's starting with those open questions to gauge a little bit if they're ready and if they want to have those sort of conversations. And as we've said already, that sometimes they're not necessarily ready, and that's okay as well. But at least giving them an opportunity, and sometimes it's more than once. So I know as in CRP, again, we've got that luxury of being able to get to know people over a number of weeks. So it might be something that, you know, you do down the track, not in that first sort of couple of sessions.
Yeah. Hannah, any other comments about motivation, readiness, you know, buy-in, those sorts of things?
I generally tend to ask the patient, which Andrew has done a really good job at asking, what is her understanding of what is happening? And she said, there is a disc that is pressing on my nerve. And I would tend to, you know, it's like puff pastry. There are layers and layers that you can peel out on that. And I would have gone, yeah, but haven't you had that since 2010? and then leave it at that, and then ask for her response as to what has happened which is different right now, which has led her to present. Like in psychology, they often talk about the concept of why this person now. So why has she needed to present now when the disc has been there? And that the answer that she would give to that would help me tailor my next sentence as to whether I go by, discs can actually impinge onto the nerves, but over a period of time, they desiccate and they can pull away from the nerve as well, or go along the lines of, oh, okay, so you're thinking that it was never fixed, and then go into healing time frames, etc. But also think about, what do you think will help you now? Or what do you think this is causing you the issues that you're having at the moment, or is there more to it? So asking them the questions just to really dig deep into their perceptions of what the patient perceives as helpful and what the patient perceives as not helpful. And again, seeing what other therapists they are seeing at the same time. So
Yes.
Are they actually really involved with the chiropractor at the moment as well? Are they actually seeing their psychiatrist? Has there been any change? And quite often I tend to do a timeline of when did they stop seeing that psychiatrist or psychologist? When did the pen flare up happen? When did they stop being too active, etc., etc. And then to really like plot it to see what can be leading to what.
What I'm hearing is, you're sort of getting, getting the story, and Peter O'Sullivan in his courses, he's done a course like a level 2 spinal course where he's actually just gotten 3 or 4 people and just literally has just asked them the question, tell me your story, and let them tell the whole story. And obviously we have time limitations, but I think one of the key things is to get their narrative. It's a great way to get buy-in, and it's also people have their description of it, and we kind of convert it into, oh, okay, your pain that was sharp, and they'll go, no, it's actually like this numbing pain that I've got. So getting their sort of descriptions of their pain is also a great way of getting their input. Question about differential diagnosis, Lester's triangle. Can I flick that to Kathy?
Yes, I was thinking of the inflammatory soup when I said about her sugars, and a bit like a bit of the kinetic chain sort of thing with the migraines and tendinitis as well. But all of those things are going to take time to fix, so you have to have her on board. Yeah.
So true. Last 2 questions. I want to ask Andrew this question first. Like the last case presentation, what would you add to like your subjective or your objective, considering all of this reflection time? What would be the things that you would add now?
I was thinking before when you were talking about letting the person tell their story, I think I would have just spent a little bit more time on that. Like Hannah was saying before, maybe getting that timeline a little bit more fixed down and really trying to get her perspective on that. And then I think probably spending a little bit more time on her beliefs as well. Like when Kathy was saying that slide presented the picture of someone that was really fearful of movement, I don't think I probably spent quite enough time talking about that, listening to her in regards to that, and then maybe addressing that a little bit more specifically.
Gotcha. Cool. And can I please ask Kathy, what would you add to a subjective and objective? I think you've already answered it previously, but as a question, can you answer that, please?
Yeah, I've said a few things, but also the sleep was the other one, the poor sleep. Yeah, and how long that had been going through, how long she'd been going through that for.
Yeah. Last question to the panel. I'm going to ask Hannah and Linda. Referral. First, Hannah. Referrals, that sort of stuff. What would you sort of be looking at?
occupational therapy for some life skills, some pacing, energy conservation, managing appointments, keeping diaries, activity logs, etc. That can be helpful, but obviously she will need to come to board and it'll need to be presented to her like how she would want it to work rather than just chucking an activity diary, which she will never even use. So talking about that, some sleep hygiene, as Kathy mentioned. The one thing that I also want to add is she's attended a pain management program. She says that she, and Andrew has recognized that she understands the relationship between psychological symptoms and pain. What has she done to implement any of those learnings? So yes, there are so many people I've come across in my career who have said, you know what, explain pain, I can actually teach that and I can do everything. And what have you done to implement it? Well, nothing really works. So, you know, that gives us a really good understanding of what their entrenched beliefs are. I used to do pain management education and people would go, yep, I get what you are saying, but that's not me. So I think that's something that we really need to understand. Or having pain management education and understanding those concepts can really reflect as, I can tell you what you as a clinician would want to hear. So that's another thing as well to be mindful of.
Beautiful. And to finish us off, Linda, a multidisciplinary team referral.
Yeah, look, I guess just echoing what Hannah said there, I think asking the client what she's found has been useful, because there's obviously been a period of time where she's probably been relatively high functioning, you know, maybe after that pain clinic sort of time frame. So sort of tapping into some of those, her own sort of resources and potentially finding out what's worked in the past and can she, you know, use those again. Yeah, certainly. I think first thing I'd be thinking of is OT again as a referral possibility to have a look at you know, sleep hygiene and pacing and fatigue management. And sometimes, you know, even if she declines the referral, and they've often, you know, I guess we're lucky in CRP, we've got a great team which we can access those therapists easily. So to get some of those resources that we can physically give to a client, whether it be electronically or handouts or something, and that can be something that she might not use now, but down the track. Similar with a social work, I think she's obviously declined, you know, a referral, but you know, with someone with that past history of mental health, I'd be just talking to the social worker. Is there something I've missed here? Is there some, you know, resource that I can give them? You know, because I know, like, particularly with the NDIS now, there's more and more sort of, you know, things out in the community which people can tap into. So, you know, our social workers have a great sort of finger on the pulse, I guess, of things of changing. And I guess, again, with COVID, there's been more opportunities for people to remotely access some of those services, which for someone who's overwhelmed by appointments could be a positive thing, to be able to access psychological support or other types of support online. It could be a good thing. And I think, last of all, I'd probably ring up Carlos and say, Carlos, I've got this really tricky patient. Is there something else I've missed? If I can get through to you on your mobile, otherwise I'd send you an email and wait for a week or two. How dare you? Eddie's laughing, she gets it. No, credit to you, Carlos. It's probably because you've been so busy too over the last couple of weeks putting this great forum together. Anyway, my point is, I guess we've got great resources within Eastern Health, and sort of tapping into, whether it be my senior or Carlos or someone else. Eddie, if she's in that same office, I knew I'd often go and say, hey, Eddie, I've got this client. What do I do? Am I missing something? Because we're all sort of able to learn off each other. And I think that's been the great thing about working in a organisation like Eastern Health, where we've got some great clinicians that work with us.
Thank you, Linda. So Sue's just said GP, a few blood tests to look at, that sort of stuff. Thank you, guys. I have like maybe 6 minutes to talk about the ambulatory pain management service as a service. So I'm just going to go do that, and then we can finish, and then we can all have a Merry Christmas. This is a statewide criteria, or this is a link to the statewide criteria for the pain management service or pain management services. If you have a look at this link, you'll be able to click on specialties, and then you'll be able to expand out that minus thing, and you can see that there are 8 categories of people of different types of pain that we accept in the pain management service. So the first one is very different from the other one. So I'm going to just talk about them in sort of like 2. So the first one is complex medication management, and then the rest are sort of all of these different types. If you click on this, this first hyperlink, what you'll get is you'll get some information first about directing someone to the emergency department. So I really like this because it's a nice revision of some key red flags that you should be looking for, in particular with someone who has complex medication management. So you'll be looking for someone who has rapidly progressing neurological symptoms. So you'll direct them to the emergency department. Suspected cauda equina, serotonin syndrome, which is what we've discussed in past webinars that we've done for the pain service, and respiratory depression. Because the opioids can actually cause respiratory depression. So the criteria, there's 3 criteria there. So high risk circumstances through SafeScript. So SafeScript is the way that the Victorian government manages the prescribers. It's a record of the prescribers and also the people that are providing the medications to patients. And if you've got multiple prescribers, you've got a multiple combination. So for example, benzos plus opioids plus antidepressants, you're sort of putting yourself at relatively high risk of something that requires medical attention. Persistent chronic pain of greater than 3 months duration. So that 3 months duration is, as we've discussed, is not, that valid. For example, someone with who's had a major back surgery, the expectation is that, that it is normal to have pain within sort of like a year. So, that person is kind of relatively excluded. With symptoms that impact daily activities, including work, study, school, career, and role. The last point, I put it in capitals, open to exploring living well with pain and learning to self-manage. So that is one of the key things. I think there are a group of people that are not interested in, our services, like, that lady with Andrew's case presentation. And there's other people that are just not interested about learning how to self-manage. So that's one of our inclusion criteria. So the 2 to 8, persistent or chronic neuropathic, cancer survivors, post-surgical trauma, primary, secondary headache, orofacial pain, secondary musculoskeletal, visceral pain, they're all ours. We can take them. Of course, direct them to the emergency department for these red flags. I will not talk too much about that. And then again, the criteria for our service is persistent chronic pain, adequate trial of treatment in the previous 12 months. So if they've not had an adequate amount of therapies, then you might actually be referring someone that is actually an acute or a subacute, but not actually like a chronic pain. And in that case, it would be like, referring me a recent twisted ankle to the pain clinic. It's just not really worth anybody's sort of time, and it's sort of directing the person to the wrong direction. At risk of functional and psychological deterioration, and willing to explore living well with pain, and is willing to learn self-management. So exclusion criteria, patients that are currently not willing to explore living well with pain, patients currently undertaking another chronic pain management program. That's happened to us a couple of times. Patients that have already completed a multidisciplinary comprehensive chronic pain management program or service. So if they've already done it and the circumstances or their readiness has not changed. Patients who only want an intervention, such as dry needling or injections. That's not really what they'll get from our service. And patients who want to receive services as a compensable patient. So compensable patients, public system, they are more directed to the private system. So this is our this is the map of the whole pain management service. So we have 3 sites, Angus, Yarra, and PJC. PJC is a specialist one. So PJC holds the subacute pain clinic, which is sort of not like what the referral criteria that we had. So the referral criteria is, plus 3 months. This is the subacute people. These are the people that are at high risk of developing chronic pain or at high risk of some sort. So we usually get a lot of people from within Eastern Health referred to this. We also have an opiate dependency and pain assessment clinic. So we have a pain specialist and addiction specialist sit in with the patient to determine what their needs are. These people have usually an OMED of 100 or more with regards to their opiates. So obviously we do intake and triage. We do a service orientation session, which tells people about what is the pain management service about. It's not a pain cure service, a pain management service. It starts to discuss the neurophysiology of pain to people, and it gives people an opportunity to have a bit of an initial needs identification. Then they can choose to go and get a medical consultation. Our service is a non-prescribing service. We believe that the GP is the central point. So what we do is we consult with the patient and then we send the GP a letter and provide recommendations on the medications. The other thing that patients do is an allied health training, service orientation session, allied health training, all on Zoom. And if they don't have Zoom capability, we can do phone. We can get them the details to phone into the group, and they can also receive videos of the recordings of that session if they have any sort of restrictions. Face-to-face isn't actually something that we're actually able to provide with these current COVID restrictions. So those are sort of like all sort of this is an individual, this is group. This is a joint assessment between, so an allied health assessment is a joint assessment between a physio and a allied health, health psychologist. And so we spend an hour and a half doing a comprehensive, holistic examination of the patient. We create we do an examination and we create a care plan for the patient. So that is considered our comprehensive assessment. After that, we look at about the patient's community resources and refer them out to the community resources. We provide them with the opportunity to be referred to pharmacy. So we have a pharmacist 1 day a week. We have CL psychiatry once a fortnight. We have individual therapies, physio, OT, psychology, and we have an attention training group, which is a mindfulness group every week, and that's one of our biggest groups. We have like 30 plus people attending every week, and they do mindfulness with a health psychologist. The gold standard and the big whopper is the pain management program. So that is a multidisciplinary team. So the doctors, pharmacists, OT, psychologists, physios are all involved in the management of patients. It's very comprehensive and intensive, 2 mornings a week. That is over Zoom as well. We have some results for EPOC. I won't share them now, but we actually have some really great EPOC results. People improve quite significantly while they're in the pain management program. So this is the pain team. This was our planning day in 2020. There's Eddie there. We've got geriatricians. We've got rehab specialists. We have Big Boss Bagita. We have pain specialists, our admin team, and health psychologists, OTs, psychiatrists. Now, referral. If you Google Eastern Health Pain Management Service, you'll get this picture here. And then if you press this link here, you'll get an opportunity to pick between different referral forms. This is the referral, like an internal referral form. Please use that. It's really good because when we do a point of care audit and whether we do everything with regards to auditing, it makes us look really good when we have this. We won't accept anything else because of that. The other thing is intra-HIP form. At the back, there is a a flowchart of what to do with intrahip forms. So you've identified that a patient is requiring an intrahip referral. Next step is call the team leader. This is my phone number here, and this is Carly Ray Jepson. I don't know if you guys know who Carly Ray Jepson is, but she's the person that sung Call Me Maybe. Feel free to call. It doesn't even have to be a referral. It can just be like, I'm having trouble with this person. One thing to say about our service is we're not everything. We can't be everything to everyone. We have a low EFT. And what that means is that we would prefer, and it actually works better for the patient, that we are already in the conversation while you're actively treating that person. So at least we can kind of link or support you. We've done double sessions as well with CRP quite often. Some final thoughts, which this is the last slide. What I'm going to do is I'm going to just allow our panelists to sort of unmute and talk a little bit about their final thoughts. But some final thoughts for me is that I hope this has been of value to you. I hope that there's going to be some practical uses for you tomorrow. And hopefully this will start a conversation. Why we chose to have a group of really skilled panelists and case presenters is because they rock. I know them, and Phil, you know them, and just find out their numbers and then email them or call them, annoy them. I think we have some really amazing people in silos within Eastern Health, and what we should do is we should just connect. Other thing is, please complete your evaluation form. And, please let us know what you thought about it, what could be improved, what you liked about it. Also ask about helping out your CLG, in particular the MUST CLG, because we need some help and we would love it. So resources, come and spend time with the Ambulatory Pain Management Service. Call Me Maybe. Also, we're recording this on iLearn, and we are also, there's other iLearn resources that are really fantastic that the grade 3s and 4s are really organising. So please look out for that and have a go at doing that. I am opening up to everybody. We are a bit over time. Anyone that wants to from the panel or Leanne, Eddie, want to make some comments, some final comments before we let people go?
I've frozen. Can you hear me? It's Kathy.
Yes, Kathy.
I think my picture's frozen, but I forgot to say, sometimes these patients present multiple times, and even if you're in ED and you're busy or whatever, it's really worthwhile looking at past notes and calling the physio that's looked after them. It's so helpful. You can say, what's my hook? How do I get in with her? Or, was she doing this last time? Is this a new thing? All sorts of things. It's really, really helpful.
Thank you, Kathy. Janet?
I probably just want to say, majority of our patients, apart from those who had reflex, are non-specific low back pain. The fact that this diagnosis does not negate the fact that as physio, we can do the clinical differential diagnosis to guide treatment and management. So the two things does not necessarily negate one another.
Yeah.
I'd like to add that just because a client's had pain for a very long time, it doesn't mean that really simple treatments, assessment and treatments can't work. So just today, I did an allied health assessment with someone, so with our psychologist, and talked to her. She was referred for neck pain, but she's also had hip pain for a couple of years. But within about 10 minutes, I was like, okay, it sounds like you've got gluteal tendinopathy. I'm pretty sure you can probably get better with this. And I'm like, has anyone mentioned that before? So it's, even though they've been to physios, they've been to chiros, they've been to osteos, it doesn't mean that all the boxes have been checked. So trust yourself that you can probably do a better, a comprehensive assessment and figure something out.
Thanks, Eddie. Any other panelists before we wrap up? I'll let Leanne wrap up for us.
I'll keep it sweet because I appreciate that everyone's really dedicated their time to attending. So thank you everyone, for attending, and we really hope it is valuable. Complete the evaluation so we get your feedback. Thank you to the working party that's pulled this together. You can probably appreciate there's been an enormous amount of work and thought, as I mentioned at the beginning, that's gone into this, and hopefully it's addressed the questions and maybe some of the learning gaps that we'd identified and spoke to earlier in the piece. So I thank you all for your expertise and your time and contributing into that. Each brought a really unique perspective, which talks to the clinical areas that we deliver care to patients. So again, it's really valuable input as well. Thanks to Carlos, again, monumental effort and greatly appreciated. I think one of the take-home messages too out of this was, again, which you spoke to, Carlos, is just that connection. We've got so much expertise across the network. It's really good to share what we know and where to find it. So reach out to your colleagues. There's multiple ways we can get in contact and really take advantage of that to support your own learning and support the care that we provide to patients. Sue, any final words before we say thank you and goodbye? No? Great. Yeah, thanks everyone. And thanks very much for attending. We really appreciate it. Have a good evening.
Good to see you all. Hi, Tracy. Hi, Jan. Hi, Scott. I'll stop the recording.